Good evening, sir.
Good evening.
Good evening, Rajendra sir.
Sir, good evening, sir. Good evening, sir.
Happy to be with you today. Wonderful. It's a need of our very good program today you arranged.
Thank you, sir. Thank you, sir. Sir, Balasubramanian, sir. Good evening. Good evening, Thiru. Thiru, good evening. Sir, Balasubramanian, sir. Sir, SPS, sir. Sir, Srinivasan, sir, vanakkam.
Vanakkam.
Good evening, sir. Thiru here, sir. Good evening, sir.
Good evening, good evening. Singaravel, sir.
Good evening, sir.
Bala, sir, good evening.
Good evening, Srinivasan, sir.
Good evening, sir. Bala, sir, good evening. All grades. Nice to see you all in platform.
சிங்காரவேல் சார் அப்பப்ப அவர் அது விடுவாரு. நான் வந்து
இல்ல, ரெண்டு அழகர்கள் மத்தியில ஒரு குரங்கு.
சார் இல்ல ராஜேந்திர சார் வந்து அப்படியே டிப்பிக்கலா சூப்பரா.
ராமர் லட்சுமணருக்கு நடுவுல ஹனுமான் மாதிரி இருக்கு.
சார் இந்த பக்கம் டாக்டர் ராமர் இருக்கா, இந்த பக்கம் லட்சுமணன் நான் அனுமாரு இடையில.
President sir, good morning.
Good evening, President sir, Ramesh Babu sir.
Good morning, Professor Singaravelu sir. Good morning, Srinivasan sir. Good morning. Good evening. Good evening. It has become evening now. Good evening.
அதனாச்சும் அந்த ஸ்டேட் இபி போயிட்டு இருக்குங்களா?
போயிட்டு இருக்கு ராஜேந்திரன். நான் அவர்கிட்ட கொஞ்சம் பர்மிஷன் கேட்டுட்டு கொஞ்ச நேரம் கழிச்சு ஜாயின் பண்றேன் சார்னு ஒரு மெசேஜ் அவருக்கு அனுப்பிச்சிட்டு நானும் வந்துட்டேன்.
நானும் அனுப்பிட்டு வந்துட்டேன். அது ஏதோ அது போக மாட்டிருக்கு. அதுல நம்ம என்னத்தை
மெயினா மெம்பர்ஷிப் டிரைவ் தான் அவங்களும் மெயின் இனிஷியேட்டிவா எடுத்து ஃபோக்கஸ் பண்றாங்க.
அதான்.
ராஜேந்திரன்
சொல்லுங்க.
அவர் டிஎம்இ சாருக்கு இதெல்லாம் சொல்லிட்டீங்களா? ரிமைண்ட் பண்ணிட்டீங்களா?
சொல்லிட்டேன். அவர் ஜாயின் பண்ணிருக்காரு. 4 o'clock ஜாயின் பண்ணிருக்காரு.
சரி சார்.
டாக்டர் ரமணா வெல்கம்.
மார்னிங், வெல்கம்.
குட் ஈவினிங் ரமணன். ரமணன் ஞாபகம் இருக்கா?
ஞாபகம் இருக்குங்க, நல்லா ஞாபகம்
இருக்கா? சி பிளாக் தானே, அது சி பிளாக் தானே நம்ம இருந்தது.
ஆமா,
அது சியா, அது எஃப், எனக்கு சரியா ஞாபகம் இல்ல. அது என்ன பிளாக்? அது சி.
பாலா சார்,
ரமணன் பாலா.
வணக்கம் சிங்காரவேலு, ரமணன், ராஜேந்திரன்.
வெல்கம் சார். வணக்கம்
சார். குட் ஈவினிங்.
ரமேஷ் பாபு.
குட் ஈவினிங் சார். குட் ஈவினிங் சார்.
சார் எஸ்பி சார், நானும் வந்து இந்த 3ஆம் பிறை கமலஹாசன் மாதிரி குட்டிக்க நடிச்சு பார்த்தேன், கத்தி பார்த்தேன், கதறி பார்த்தேன். சார் பாலா சார், பாலா சார்
3 தடவை கூப்பிட்டாரு. கோட்ல சார் கூப்பிடுறாரு.
எங்க கோச்சுக்கு போய் நான் யூஸ்வலா எல்லாம் 1 மினிட் முன்னாடி தான் ஜாயின் பண்ணுவேன். உங்களுக்காக 5 நிமிஷம் முன்னாடி ஜாயின் பண்ணிட்டேன்.
சார் மனோஜ் சார் வெல்கம் சார். மனோஜ் சார் வெல்கம்.
மியூட் பண்ணு.
ரமேஷ் பாபு ஸ்டான்லி ஸ்டூடெண்டா?
ஆமா சார், நான் ஸ்டான்லி சார். ரமணன் எனக்கு ஜூனியர் சார்.
ஐயோ, உடனே தெரிஞ்சு போச்சு. இந்த ஸ்டான்லி மாத்திரம் விடவே மாட்டீங்களே நீங்க.
ஸ்டான்லி எக்ஸ்பிரிட் பாங்க சார்.
ஸ்பிரிட்
ரமணன்,
ஸ்பிரிட்
ரமணன்
நல்லா ஞாபகம் இருக்குங்க. சி பிளாக்
பண்ணிருக்காரு அவங்கள. ரமணன் ராகிங் பண்ணிருக்காரு அவங்கள.
இல்ல, அவர் ரொம்ப நல்லவருங்க ரமேஷ் பாபு.
ரொம்ப ரொம்ப நல்லவரு.
ரமணன், வெங்கடேஷ் கார்த்திக் எங்க இருக்காரு?
அவரு யாரோ கடைசியா சிங்கப்பூர்ல இருக்காருன்னு சொன்னாங்க, ஆனா சரியா தெரியல.
அவரு ஸ்ரீதர் வந்து துபாயில இருக்காரோ?
ஆமா,
ஸ்ரீதர் துபாயில இருக்காரு. சிவகுமார் ராய்பேட்டையில தான் இருக்காரு.
ஸ்ரீதர் துபாயில இருக்காரு, நியூனட்டாலஜிஸ்ட். அந்த ஸ்ரீதர் தானே சொல்றீங்க?
ஆமா ஆமா ஆமா, இவங்க எல்லாம் கிளாஸ்
எம்டி படிச்சாரு.
ரமணா, நீங்க 91 பேட்சா?
89.
ஓகே ஓகே ஓகே.
Good evening, all of you. Good evening, sir.
Jalil Ahmed sir.
Good evening.
Good evening, sir.
Jalil, good evening.
Welcome.
Ramanan sir, good evening, sir. We are.
Good evening, sir. Good evening, sir.
Jalil, good afternoon.
Good afternoon, sir. Sir, you have given us a chance for infectious disease chapter, sir. Now, Naminathan, he called me today. We will do it.
Yes, sir. நான் கொடுக்கல சார், அவங்க சென்ட்ரல் ஐஏபி கொடுத்திருக்காங்க இன்ஃபெக்ஷன் டிசீஸ். நான் ஏதோ
சார் பெஸ்ட் விஷஸ் சார். பெஸ்ட் விஷஸ் ஃபார் சக்சஸ் ஆஃப் ஐடி CME சார்.
Thank you sir.
ஐடி கான்ஃபரன்ஸ்
சூப்பரா
நவம்பர் 1920 இவங்க எல்லாம் பேசுனாங்க. நேமிநாதன்
நல்லா பண்றோம் சார். நல்லா
பண்ணிடுவோம் சார்.
நாங்க நேஷனல் கிரிட்டிக்கல் பண்ணோங்க சார் KMC கட்சியில. அதே மாதிரி இது இன்ஃபெக்ஷன் டிசீஸ் பண்றோம் சார். Coimbatore team will do the best, sir.
நீங்க உங்க கோஆபரேஷன் தான் சார். நான் சும்மா உப்புக்கு சப்பானி, நீங்க தான் பண்ண போறீங்க.
No, sir. நீங்க சேர்மன், நீங்க உத்தரவிடுறீங்க, நாங்க பண்றோம் சார். ப்ளீஸ் சார்.
அவர் அப்படிதாங்க சொல்லுவாரு, உப்புக்கு சப்பானியும் பாரு, அப்புறம் அவர் தான் ஆல் இன் ஆல் இருப்பாரு.
நான் ஒண்ணும் பண்ண மாட்டேன் சார். எல்லாம் இவங்கெல்லாம் அருமையான டீம் ஃபார்ம் பண்ணி பண்ணிடுவோம்.
மேடம், குட் ஈவினிங். மேடம் ரமா, மேடம் இஸ்மாயில், குட் ஈவினிங்.
Good afternoon, sir. Good afternoon.
ஹலோ டாக்டர் இஸ்மாயில், டாக்டர்
Hello,
ரமா.
sir.
Good evening, Ismail sir. Good evening.
Ismail, good evening.
Good evening, good evening, sir. Good evening, sir.
ராஜேந்திரன் டியூட்டில இருக்கீங்களா?
அவர் எப்பவுமே எவர் ஆன் டியூட்டி.
Srinivasan, sir. Good evening. SB sir, good evening.
குட் ஈவினிங், குட் ஈவினிங். எப்படி இருக்கீங்க?
நல்லா இருக்கேன் சார், நல்லா இருக்கேன்.
ஸ்ரீனிவாசன் சார் பார்த்து ரொம்ப நாளாச்சு.
அன்மியூட் பண்ணுங்க சார்.
The audio is not functioning, sir.
Srinivasan sir,
Unmute பண்ணுங்க சார்.
Yes sir. I wish you sir. It's nice to see you again after a long time, as you said.
Manish sir, your audio, please check your audio, sir. It's not coming. Actually, unmuted only.
குல்பேட் வீட்டுக்கே போகலையா?
அப்படியே உட்காந்துட்டுங்க.
Even on Sundays, sir, Sunday-யும்
இல்ல, இன்னைக்கு கரெக்டா இதாயிடுச்சுங்க. அப்படியே
சார், குட் ஈவினிங்.
நாராயண பாபு சார்.
Good evening, sir.
குட் ஈவினிங்.
Good evening, sir. Good evening, Gopal.
Good evening, good evening.
Madam, good evening. Rama madam, good evening.
கோபால், குட் ஈவினிங்.
ரமா மேடம் அன்மியூட் பண்ணனும்.
Good evening, sir, to all of you.
Good evening, good evening, ma'am.
Good evening.
Dr. Tangavelu, Dr. Gopal, all good evening.
Good evening, sir. Good evening, sir.
Srinivasan sir, பாண்டிச்சேரியில எலெக்ஷன் இல்ல.
பாண்டிச்சேரியில என்ன எலெக்ஷன் சார்?
நீங்க கையை தூக்குறது பார்த்தா
யாரோட இதுங்க?
எந்த போஸ்டிங்ல இது வரைக்கும் நின்னது கிடையாது சார்.
DME sir, good evening.
சாப்பிடுற டைம் இருந்துச்சு.
I know my
Narayan Babu sir.
DME sir, நாராயண பாபு சார், welcome sir.
திருமுருகன் கூட ஓட்டு போட மாட்டார் சார். எனக்கு
DME sir, good
Good
evening.
evening, sir.
Sir, good evening.
Good afternoon.
நான் என்ன திருமுருகன் கூட ஓட்டு போட மாட்டேன் சார். அதனால நான் நிக்கவே மாட்டேன்.
நாராயண் பாபு சார், குட் ஈவினிங்.
குட்
Sir,
ஈவினிங்.
எதுக்கு என்ன கூப்பிடுறீங்க?
எல்லாருக்கும் வணக்கம் சார்.
வணக்கம் DME.
எல்லாருக்கும்
DME sir, வணக்கம்.
சார். வணக்கம் சார். எல்லாருக்கும் வணக்கம் சார்.
Good evening.
டாக்டர் பாலசங்கர், ரமணி,
எல்லாருக்கும் வணக்கம் சார்.
ஜனனி,
எல்லாருக்கும் வணக்கம் சார். எல்லாருக்கும் வணக்கம் சார்.
சார், ரமேஷ்
நல்லா
பாபு
இருக்கீங்களா
சார்,
சார்?
உங்களுக்கு இன்னைக்கு தான் என்ன இன்ஸ்டலேஷனா சார்? இன்னைக்கு
ஆமா
காலையில
ஆமா ஆமா சார். இன்னைக்கு தான் EB வந்து EB மீட்டிங் as well as installation ceremony.
காலையில தான் தாலி கட்டினாரு.
புது மாப்பிள்ளையா?
புது மாப்பிள்ளை.
ராஜேந்திரன் சார் 401
Start, sir.
சார் 401 ராஜேந்திரன் சார்
Yeah,
ஆரம்பிங்க.
start.
கல்யாண
Many of
கலை.
them, sir, please, silence, sir. So many of them, they join in the YouTube, sir. We can start a meeting, and it is panelisting only. And on behalf of APTNC, I welcome one another. First, we will start with the pediatrician prayer by Dr. Gopal Subramaniam, our president.
அனைவருக்கும் மாலை வணக்கம். குழந்தை மருத்துவ இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பது பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தன் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதவற்றை காரணத்தினை ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களும் நேரங்களிலும் அனைத்து மக்களையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. And respected IAPTNC Dynamic President, Dr. Ramesh Babu. And today's Chief Guest, Dr. R. Narayana Babu, sir, Director of Medical Education, Government of Tamil Nadu. And
Today, program convener Dr. S. Balasubramaniam sir from KKCT and National Task Force Committee Chairperson. And today's moderator, Dr. Tangavelu sir from Chennai, Dr. Rama Chandramohan, Director ICH Stanley, Dr. S. Balasankar sir, ICH Madurai, and Dr. Elilasi Madam, Director ICH MMC, and today's speaker, Dr. Professor Dr. A.V. Ramana, and Dr. Manoj, Dr. Dhiran Gupta from New Delhi, and all the OBs, office bearers, Dr. M. Ismail sir, President 2021, Dr. K. Suresh Balan, President-elect 2022, Dr. J. Balasubramaniam, Joint Secretary, and AAA Dr. Thirumurugan Sarani, and Vice President Dr. Annamalai Vijayaraghavan sir, Dr. Dashani, Editor, and all the Central EB and as well as State EB members. And on behalf of IAP TNSA, I welcome one and all for this wonderful CME. First of all, I thank our DME sir readily accepted as chief guest for this event. And I thank Dr. Balasubramanian sir who has concerned as organized this wonderful CME. Now I welcome our dynamic president, Dr. Ramesh Babu, to deliver a president's address.
Good evening all. Respected chief guest of today's event, our beloved Director of Medical Education, Professor Narayana Babu sir, convener for today's event, Professor S. Balasubramaniam sir, the moderators for today's CME, Professor Tangavelu sir, Professor Rema madam, Professor Balashankar sir, and Professor Elilasi madam, and the faculties of today's CME, Professor Ramanan sir, Professor Manoj sir, and Professor Dhiran Gupta sir, and our dynamic secretary, treasurer of IAP TNSC, president-elect of IAP TNSC, past president of IAP TNSC, and all state office bearers and EB members, central office bearers and EB members, and senior professors, faculties, my teachers. It is a pleasure on behalf of IAP TNSC. I am welcoming you all for this CME on Omicron, the implications of the third wave, and as well as the status of COVID vaccination in our state. It's a pleasure for me to participate along with you in the CME. Hope this will be useful for all of our pediatric fraternity, and I wish it a great success. Thank you for the opportunity, Rajendran. Thank you.
Thank you, Dr. Ramesh Babu. Now I welcome our President 2021, Dr. M. Ismail sir, to deliver the address.
Respected DME, Dr. Narayan Babu, Program Convener, Dr. Balasubramaniam sir, the moderators, Dr. Tangavelu sir, Professor Elilasi, Rama Chandramohan, and Balashankar sir, and of course all the speakers and as well all the functionaries of IAP TNSC. Good evening to all of you, and this is a topic of very good interest, and of course it will be timing is very much appreciated because Omicron is just weaning or waning, we don't know. The other stage is on the pipeline, so I think we need to update our knowledge about COVID. I wish you all a happy learning. Thank you.
Thank you, Dr. Ismail sir. Now I request our Director of Medical Education, Government of Tamil Nadu, Dr. R. Narayana Babu sir, to deliver inaugural address and inaugurate the CME.
Respected President, respected Secretary, IAP TNSC, dear doctors, respected President-elect Dr. Ramesh, Dr. Gopalakrishnan, and dear Dr. Rajendran, respected Dr. Balasubramaniam, Dr. Tangavelu, Dr. Rama Chandramohan, Dr. Elilasi, and the speakers, Dr. Ramana and Manoj. Really, it's a very pleasure to be with our pediatric forum for this discussion on pediatric COVID. Really, I'm very happy on behalf of the government because all the time in the first wave and second wave, the third wave, they told it was reserved for the pediatric. Luckily, our pediatric, as usual, our children are least affected. And to my surprise, the pediatric was on treatment as of now is around 6 children in the government institutions. and around about 100 children are affected in the third wave. Compared to the first and second wave, there was crossed 1,500. So it's a very good news. We are having less number of pediatric. As usual, as contrary to other thinking, that pediatric is a vulnerable group which will be affected. I will presume that the pediatric is the strongest group, as I was personally seen. The first wave and second wave, the pediatric children will be accompanying the parents in the houses in the hospital, but they are not affected. The first wave, I've seen in the hospital children, 2 children of a family accompanying their father and mother staying in a single room for 2 weeks, but they are not affected. And the same thing is also happening now. Though we have made reserve 10,000 beds with oxygen facilities, because we don't take any chances. As usual, we are having around 1,40,000 beds in the DME side, 70,000 beds, 10,000 beds, especially as instructed by our task force. We get ready for pediatric with the state-of-art pediatric facilities, pediatricians with the training, with the adequately trained nurses. Yet, we are very happy to see less number of pediatrics affected, but it's a time that each and the knowledge about the pediatric COVID should be highlighted to all the nursing faculty, paramedicals, and the overall associated with the pediatric, apart from the pediatricians, very well about the pediatric COVID. And really, I have to appreciate the IAP, TNSC for having always at the time of any crisis, they're coming forward with the recent topics. And the burning topic as of now is Omicron. As everybody knows, 85% more plus is Omicron. Less than 15% is Delta variants. Most of the patients admitted are Omicron now, is taking it. Even that, the pediatric age group is resistant. And if not, the symptoms and signs which is seen in the adult, at least they complain 5 days symptoms in adult. But pediatric, I have seen personally, less than 1 day, only an episode of fever, that's all. No myalgia, no sore throat, nothing. Only one episode of fever, either in the day or night. Subsequently, they're overcoming that and they're running like anything compared to the adult with the 5 days of the symptoms. So all the time, I'll place my children's and pediatrics age group high above everybody. And it's a high time also for the pediatricians to see the immunological response to the children, because I'll place and record the immunology, the immunity of the children are far above than anybody. Though they are in the same house, they are not affected. Though they are in the same hospital. So the immunity concept, the concept is without vaccines. You know one thing, 1 year has passed with vaccines and 2 doses of vaccines people are getting affected with again Omicron and Delta group. Pediatric age group without vaccine, without much of protection of mask also, we see children playing without mask. They are resistant to see any specific immunity in the children which acts them or helps them. So it's a knowledge sharing exercise, really very happy and congratulate the team and the speakers and IAP TNMC for organizing such a wonderful brainstorming thing. Thank you very much for asking me to come over the media. All the time I will be very happy as a pediatrician. They are doing a yeoman service, especially TNSC is doing a wonderful service for the knowledge improvement and the training aspect of the doctors and nurses. Congratulations and thank you.
Thank you, sir. Our DME, sir. I think we are as a family of pediatric member doing really tremendous work for our pediatric community, as well as children, as well as our IAP members. Whenever you are requesting, you are doing all the necessary steps at the government level you are taking. I'm really thankful from IAP TNC. We are really thankful to you, sir. Thank you very much.
Thank you, sir. Thank you very much, sir. Thank you. Thank you.
And now I welcome our today's program convener, Dr. S. Balasubramaniam. He is currently advisor, Pediatric COVID Protocol Committee, Ministry of Health and Family Welfare. He is currently his ID, that Infectious Disease Chapter National Chairperson. Now he is Head of the Department and Director KKCT. I welcome Dr. SPS, sir. Please
deliver the program convener address and we can take our sir, please.
Thank you, Dr. Rajendran. Thank you for giving me this opportunity to convene this specific program on Omicron and the third wave. When Dr. Rajendran called me and told me you call good speakers and organize a program to update the pediatricians about Omicron, I had absolutely no difficulty in choosing the best across the world. And I have arranged for three very senior experts to discuss the implications of the Omicron or the third wave in pediatrics. There will be 4 sessions today. The first one is on the third wave in the West Europe, South Africa, and its implications to India. The second one will be about the epidemiological viewpoint of the Indian scenarios with specific reference to the third wave and Omicron and with specific reference to pediatrics. And the third one will be on Indian experience in relation to management of adult and pediatric COVID. And I would do a small session on practical dilemmas and solutions in the management of children in third wave. The first speaker is Professor A.V. Ramanan, who's our own Indian product from Chennai and Stanley Medical College. Professor Ramanan is very well known to almost all the pediatricians all over India and particularly in Tamil Nadu. He is the professor of pediatric rheumatology at the University of Bristol and the Bristol Children's Hospital in the United Kingdom. He is one of the top pediatric rheumatologists in the world. And one of the main reasons we had decided to request Dr. Ramanan to speak today is because Ramanan is very actively involved in the research related to COVID-19 and MIT-C. He has been part of the steering committee trial of tocilizumab in India, part of WHO meta-analysis of tocilizumab in COVID, which was published in JAMA recently. And he's a member of the steering committee of multinational trial of baricitinib, a cheap rheumatological drug in COVID-19. And this committee had come out with 2 papers in Lancet. And he's part of the prestigious and unique recovery pediatric steering committee looking at treatments in children with COVID. And we are eagerly awaiting Dr. Ramanan's input on the use of IVIG and steroids in MIS-C. With this brief introduction, I would request Professor A.V. Ramanan to start the proceedings with his session on the third wave in Europe, UK, and South Africa, and its implications for India with specific reference to pediatrics. Over to my friend, Professor A.V. Ramanan. Thank you.
Thank you very much, Dr. Balasubramaniam, and thank you for all of those assembled. It's an absolute pleasure and privilege. I never say no to any meeting which entails speaking to my fellow colleagues in Tamil Nadu. As he outlined, I am a product of Stanley Medical College, so it gives me great pleasure to be able to share. I'm just trying to share my screen, so bear with me for a second, please. If someone can confirm, you can see my screen fine?
Yes, yes, yes.
So it's a challenging topic, and when Dr. Balasubramaniam first asked, for 2 years, I've been working on multiple trials of COVID in both adults and children. But the impact of Omicron from South Africa, US, and UK, what I'm going to show, most of it is anecdotal data or unpublished preprint data. And that's the problem, because this variant has taken upon us within a matter of months. So we're still in the stages of collecting the data. So what I show is not published, and it's widely available, but not published. So there is always that small element that I have to declare. So we have a lot of knowledge, but limited published data. I'm going to touch on three aspects: the South African data, which is from one province of South Africa, which has got a lot of relevance to our own scenario. It's a preprint and it's not been peer reviewed, so there is that caveat. And then, which is hot off the press, a couple of weeks old, or not even that much, a couple of days old, US data, which is preprint. And then personal experience, as well as, because I sit on the Recovery Steering Committee, which, as you know, has led lots of trials, I have access of both anecdotes as well as the UK government's data, which I sliced on Wednesday last week to prepare the slides. So it's a few days old. So let's look at some pediatric specific data. And as most of you know, this variant was thought to have stemmed from South Africa. And I think we should be careful in pinning variants to different parts of the world, and which is one of the reasons why WHO specifically started using a different nomenclature as opposed to calling these variants by their names from where they originated, because it carries the risk of stigmatizing those parts of the world. And in spite of the best efforts, unfortunately, several countries started excluding travelers from South Africa, which I think is not the way forward, because what we have learned is it's not possible to really contain these variants by travel restrictions alone, although being cautious is certainly helpful. So this one talks about the rise in pediatric COVID-19 hospitalizations in children. But actually, if you analyze the data, it's very different. And it's, as the Director of Medical Education pointed out, it's very reassuring that children have been relatively spared in all forms. South Africa is particularly poignant because they seem to have had every variant that we've had. So they've had, this is their fourth wave rather than the three waves that the rest of the world experienced. So they had a limited wave with Alpha, and most of you may remember the South African Beta variant was the one which caused a lot of concern initially, because it was another of the variants for which some of the vaccines were thought not to be that effective. And then they had the Delta, like the rest of the world, in July, August 2021. So just a couple of months behind the peak in India, which I suspect was May, June, but we may hear more from Dr. Murhekar. And then you see the start of the worldwide panic was sometime in mid-November, which then went on all the way to mid-December. But what is significant about these waves is you can see the more gradual rise and the gradual drop of the Alpha, Beta, as well as the Delta waves, whereas this sharp, steep rise for Omicron in South Africa, and the steep fall as well. And that suggests two things, which I suspect almost everyone in the street is now aware, that this is a more transmissible variant, but because it's more transmissible, you get that peak much sooner. Unfortunately, the transmissibility is not proportional to virulence, so it does certainly appear less virulent. When this data was first reported, as always happens, the Western analysts who look at these data were worried that this may not necessarily reflect the scenario in the rest of the world, because the South African population, they argued, was young. But the key, which I think was offering a lot of promise, which was missed, is bulk of the adults and children, that is the parents and the children in this province, were not vaccinated, which is a different scenario to the incredible success of vaccination in India and in the rest of the world. So this is extremely reassuring data in the presence of very low levels of vaccination. Now let's focus, as most of us are pediatricians, and this is a pediatric meeting, let's look at the pediatric data, and this is looking at pediatric COVID-19 cases. That means they may have had some symptoms and therefore have had testing and may have turned up positive, but not necessarily hospitalized. I'll come back to the hospitalization. So the yellow bars are the 15 to 19-year-old children. The gray bars are the 10 to 14-year-old children. And then the red bars are the 5 to 9 and 0 to 4. And I think some of the increased cases that we see in the 0 to 4 is probably more what we call is a statistical bias, because by 2021, November, December, the presence of COVID in our midst was well recognized. And when children which are 6 months, 9 months old get a fever or any symptoms, in the past, we wouldn't have done these sorts of viral testing. They now get tested. And as soon as they have something like a SARS-CoV-2 Omicron variant, there is a heightened level of anxiety which might lead to admission. So it doesn't mean that these children are ill enough to need admission, but there was a heightened level of anxiety. And particularly the younger the child, most of us tend to be more safe because of our concerns. And here's looking at the proportion of tests which turned positive. And again, it's very salutary if you look at the fact in their Delta wave, the proportion of positivity is the blue bar is the number of SARS-CoV-2 tests they do. And then the orange is the number of positive SARS and the percent positivity. And there is no major difference except that the peak is more stark. So the person who are turning positive, of course, there's lots of caveats of how many tests they do and whether it's community-wide testing or testing of only the contacts or testing of only those who have positive. But there are no major concerns is the point that's being shown. But what you're seeing with Omicron, which I suspect was replicated in US, UK, and probably is in India, is the extraordinary transmissibility, which is leading to a very vertical curve of the number of people who are getting in contact, getting, if they get tested, turning positive. And that you can see is almost much higher than the Delta and the Beta peaks, certainly much less than the Alpha peaks, where countries shut down their borders much more quickly. So then coming back to the total number of COVID-19 admissions, this is across children and adults, you see clearly, and this is the first sign of good news, that the admissions are nowhere near what was seen with Delta and Beta in South Africa. So clearly demonstrating that Omicron is a much more milder variant, even in adults. Why did the pediatric admissions go up? There are multiple explanations for the South African data. It might be heightened anxiety. It might be the fact that the children are more likely to be unimmunized or non-immunized compared to adults in terms of vaccinations for this. And these reasons with even mild symptoms and the fear of the variant that was created in late November and December and its potential to have so many different mutations, which took as a surrogate marker of virulence in people's mind, which wasn't necessarily proven with passage of time. South Africa, like India, has two sectors, the private and public sector. And I think you can see that the admissions in private sector, which is in the more affluent populations, was slightly higher, demonstrating maybe the anxiety levels in the paying public who wanted their children to be in the secure environment of a hospital. So I think the public sector admissions are a more true indicator of the need for hospitalization. And even there, probably the levels of anxiety played a huge role. Again, I've split it into different color codes as they have done, demonstrating the admissions in children. So the green represents 0 to 4 years, which is the highest group which is admitted. And I would again make the case that this is probably because in the younger children, there was a greater deal of concern. And you can see that as they get older, people are more comfortable watching and observing them. And as was pointed out in the introduction by the DME, that these children just had mild symptoms, but when they are young, there is a lot of parental as well as anxiety by the healthcare professionals, which might result in these children getting admitted for a short periods of time, maybe a day or two, and being observed. So what I've highlighted in red, and this is looking at multiple hospitals in South Africa, is clearly the deaths. They only had 4 deaths, and all 4 of these pediatric deaths were in those with significant comorbidities or previous underlying pathologies, which was well recognized, and I'll explore them in a bit more detail. So if you look at the age group, the under 1 was overrepresented, and that, as I pointed out, might be because of the nature of that age group. There's no particular gender predilection, so it was fairly equal. And the major symptoms are not a surprise to any of us. They are upper respiratory tract symptoms, fever, cough. We've always noticed, not just with primary COVID, but also with MIS-C, that gastrointestinal symptoms seem to predominate in children compared to adults. And that's expressed as about a fifth of the patients having diarrhea and a fourth of the patients having vomiting. And then a host of other non-specific symptoms, which we see in most viral infections. And you look at some of those with comorbidities, no surprise, you see that about 7% have underlying hematological or oncological diseases. South Africa does have a high HIV population, positive population, unfortunately, so they constitute about 5%. And type 1 diabetes is certainly increasing in several parts of low and middle income countries, and South Africa is no exception. So you have 5% of type 1 diabetes positives. And there are different types of HIV exposure. So if you marry the two, it's almost 10%, those who are exposed and then those who are infected, which is having low CD4 counts. And then a host of neurological conditions broadly categorized as cerebral palsy. There was a lot of concern about asthma being a risk factor, and we now know that isn't so much of a risk factor. But again, I've highlighted one thing, incidental COVID-19 diagnosis. It's something we pick up in our hospital. We bring patients, children for routine surgeries, they have a swab, and then we pick up that they're COVID positive. So almost 40% of the patients are incidental COVID-19 diagnosis. And that again is extremely reassuring. And then if you look at the laboratory markers of those who are admitted, most of them are bang normal except for C-reactive protein, which is only a mild elevation. So compare this with sick adults having delta C-reactive protein, you'll have CRPs of more than 100, and we know that CRP is a surrogate marker of IL-6, which is why we use drugs like tocilizumab in adults. And in fact, even in the recovery trial, to recruit to studies, you needed a CRP of more than 75. So the fact that the CRP is low suggests a limited inflammatory response. And then you see very minimal elevation of white counts. So essentially a mild illness, and in 40% an incidental diagnosis. And therefore, most of these patients, except those with comorbidities, got better with just a day of admission, observation, and really small percentages of those with comorbidities required any level of actual care in terms of intensive care. And you can see the small numbers needing high flow oxygen, which is 2%, or ventilation, and all of them. And as I said, there were only 4 deaths, and all of them had significant comorbidities. And the bulk of these patients get admitted and discharged, and the younger ones probably were admitted primarily for observation. So let's look at this data, which is only a few days old, which is looking at the American data, and I've summarized it. So they look at the electronic health records of almost 600,000 SARS-CoV-2 infected patients from a large American database. Of these, 14,000 had infection in the Omicron period, which is between the 15th of December to the 25th of December. And the remaining 550,000 odd were the Delta cohort, which is between January 2021 till this 15th of November. And this is pretty similar for UK as well. So they compare 550,000 over 11 months of Delta variant with 1 month of Omicron, which is 15,000, and see the rapid explosion in terms of Omicron. And of these Omicron patients, 30% were pediatric patients. This is interesting because America or US is one of the earliest countries which went for pediatric vaccination. So they went for the 12 to 18 long before the rest of the world, and then went for the 5 to 12 long before the rest of the world. So it is obvious that the reason 30% of the pediatric patients were these positivities is because compared to adults in North America and in Europe, children were thought to get more exposure because they were not as profoundly vaccinated as the adult populations with boosters are. So again, some good news for you, and I've just given you a headline. Amongst the first column is those with Omicron versus Delta. So you have a lesser chance of coming into hospital, even to the emergency room or accident emergency. So 4.5% compared to 15% for Delta. You have a tiny risk of being hospitalized, 1.75%, almost half of that of Delta. ICU admission is 3 times less likely for, this is adult data across the spectrum for Omicron compared to adult. Chance of mechanical ventilation incredibly lower compared to Delta. So all of these suggesting that Omicron, whether it evades a vaccine or not, is certainly a much milder variant than it was feared originally. And in pediatrics specifically for this group, in children under 5, the risk of hospitalization was significantly lower, 4% compared with 21% in Delta. And the risk of being hospitalized is less than 1% compared to almost 3% in the Delta. And this was for children across all age groups. I picked up 5 years and under specifically because that is the age group which is not vaccinated and which in the South African data seemed to suggest there was a high risk of hospitalization. And I suspect some of that was people being cautious and being anxious rather than actually the children or the illness mandating hospitalization or admission. So I'll finish off with a bit of UK picture. I'm not going to separate it out for adults and children, but I can speak from personal experience and then we can discuss this when Dr. Balasubramanian has any questions. I did a data cutoff on the 25th of January. Again, you can see the rapid spike. For us, the Omicron spike was probably last couple of weeks of last week of December, first week of January, really. And you can see the huge spike compared to the previous 2 waves, which were more gradual. And this is looking at proportion of people with at least 1 positive result. And you can see the explosion of cases. We never hit this levels in Delta or in the previous peak. So there is a huge proportion of people testing positive very quickly, and then the wave seems to subside as quickly as it comes. It's truly a wave compared to the previous ones, which seem to gain momentum with passage of time. And you can see how it goes up quickly, but comes down. So by the time of the second week of January, we have from going about being 60% positive to rapidly declining numbers, so which is very encouraging, really. And this is looking at patients admitted to hospital. Again, this is the peak in UK, which is the Delta. Our vaccination really started in late December 2021, but it went through elderly people. So the peak hospitalization was really at the January, February months of last year. And you can see the hospitalization is way less, half of what it was for Delta. And this is at any point in time, patients admitted to hospital. The previous one was hospitalization from positivity. And you can see our peak was close to 40,000 beds at one point in time in mid-January 2021. And fast forward a year later, it's less than half that number. And even here, half of the patients, we don't know if they are incidental COVID positives with Omicron rather than true COVID-related admissions. Whereas here we are almost certain that 90+% of those in hospital with COVID positivity were because of COVID rather than incidental positivity. Then looking at mechanical ventilation, which is always a big source, you can see that the need for mechanical ventilation in Delta was huge, 4,000 beds in our peak, and is a lot less, and is coming down rather than going up in spite of increasing positivity. This is UK's vaccination. Of course, the role of booster is yet to be firmly established, but we know that since we can't quantify the T cell responses, but looking at B cell responses, having high levels of antibodies may have an impact. So the booster was started in September, late September in UK. So we have 80+% of the population having the first dose, close to 80% having the second dose, and close to 60% having had a booster, which is as of 25th of January. UK was late to start vaccination for children. We currently only vaccinate the 12 to 18-year-olds. And for the 5 to 12-year-olds, vaccination is recommended only if there is a family member who has a significant illness or the child has a significant comorbidity. And this is the number of vaccinations we gave. So at the time of booster, there was a huge booster uptake in terms of having close to 800,000 to even touching 1 million patients per day. But since now 60% of the eligible population has had its booster, the number of vaccines administered per day has come down to closer to 100,000 or even less than 100,000. I'm going to show you some community data, because the point I made from the South African data was if you go around checking healthy people currently, even in India, if you take 100 people off the street, you may have a percentage of people who will test positive for Omicron with absolutely no symptoms. So that's exactly what this group does in Imperial. So they did 3 surveys. The first one was in 2021. They sent invitations to just shy of 1 million people, of which you have 100,000 responding. So these are taken off the street, random population, and asked if they would participate in sampling. And at that time, you can see that in November 2021, of those who replied, 92% had the Delta variant. They all get sequenced in this random population. And then they did another one between the 23rd to the 14th of December 2021. So Omicron had not got established yet. Again, sample size of almost 100,000 random participants in the community, 92% Delta, 7% Omicron. And the key data, which I'm going to show you now, is between the 5th and the 20th of January, they again sample another 100,000 random, and this includes people from the ages of 5 onwards. And in a matter of just weeks, Omicron is now constituting almost 99% of the sequenced of these 100,000 random members of public. So in a matter of 4 weeks, we had gone from 90% Delta predominating to 99% Omicron. So it's the rapid transmissibility, milder nature, and its ability to become the dominant strain in the community, which I suspect is what's happening if it's not happened already in India. I won't go through this, but just to show that this random sampling is heavily stratified to ensure that it accounts for all types of people, although there may be slight overrepresentation of key workers and healthcare workers, because we know that they're more likely to be incidentally positive and all levels of prevalence. And so in this random community sampling, you can see our peak was somewhere in the first week of January, where the probability density or the most likelihood of someone in the community testing positive is high, and then comes down. And again, I highlighted, because the children under 18 are the ones which were last to be vaccinated, and children under 12 in UK are still not offered the vaccine, you find that the percentage positivity in a random sampling is higher in children under 17 compared to 18 to 54, which is this blue bar, and 55 and over. And this 55 and over is the group which is most likely to have had not 1, not 2, but 3 vaccines, because it was again stratified by age. And the group which is under 17 is the least likely to have had a vaccine, because it's not offered to most of them. And therefore, the prevalence of the sampling and the dominance of the variant is not a surprise. And this is, again, looking at percentage prevalence. So the gray is Delta and the orange is Omicron. The gray was done between November to 23rd to 14th December, and orange. So for the pediatricians in the audience, the key is certainly more children are becoming positive with Omicron, maybe because of transmissibility, maybe because we are less careful. And most importantly, because this group is less likely to be vaccinated. But that is not translating into more illness. So children are more likely to be positive in the Omicron variant, but not likely to be ill. So I'll finish with my key message. I hope I've demonstrated to you from 3 countries, South Africa, US, and UK, that Omicron is certainly more transmissible, but appears to be a milder illness in the vaccinated population. And even in the unvaccinated in South Africa, it wasn't that bad. Children certainly are not severely ill, in spite of the majority of these children, particularly in South Africa and the UK, not being vaccinated. So in all, reassuring news. And I thank you all again for, and all the organizers for giving me an opportunity.
Thank you, Professor. Thank you, Professor Ramanan. Actually, I forgot to introduce the moderator for Dr. Ramanan's session, because Dr. Thangavelu does not need introduction to this august audience. Dr. Thangavelu is one of the senior most brilliant pediatricians in Tamil Nadu, and I'm happy that he's moderating this session. My apologies to Dr. Thangavelu. For not introducing him. We have a lot of personal questions. Dr. Thangavelu, you can take 10 minutes to discuss with panel questions. Thank you, Professor Tangavelu.
Thank you, sir. Thank you very much. Good evening, everyone. And of course, I don't have much to say rather than asking more questions. Only that this is the first time in the World Health, if you look at it, if you compare the COVID, the original Wuhan virus as probably comparable to a test match, probably the Omicron has placed a 2020 match. It started on 27th November. It's born on 23rd November, named at 27th November on 5th day. And within some 3 to 5 weeks, it has spread to the whole world. Anyhow, many studies have, not studies, at least all their information passed in the messages that it found to be high transmissibility with the significantly younger population affected, more vaccine breakthrough rates, significantly less hospitalization, oxygen requirement, and ICU care. Professor A.V. Ramanan has very nicely covered all aspects of Omicron in these 3 countries and his opinion on it. And it was very, very useful way he has presented both the unpublished papers as well as the papers and images so that we can understand it better. I have a certain personal thing that one is in the last maybe 2 or 3 weeks, speaking from our hospital experience, they say only about 60 to 70 children present with COVID positivity, either by video calling or the OP attendance. When they follow up, none of them require hospitalization. All these 60 children were treated as outpatients along with the family members. None of them required hospitalization. We made a video call and none of them developed any problem requiring hospital admissions. Only one child we had presented with steroid-resistant nephrotic syndrome. Child came with acute kidney injury requiring multiple organ support and tried within 24 hours hospitalization. The child found to have Omicron positivity. We're not very sure whether Omicron may be a reason for the death of this child, probably the underlying illness. Apart from that, there's no other sick children requiring admission. Of course, we are in the private sector now. But though it's considered as less hospitalization, less need of PICU care, in our PICU group, from many intensivists reported cardiac arrhythmia, good number of children with pneumonia, one child on ECMO, refractory hypoxemia in adolescent kids, 1.5-month-old child on HFO. So I request Professor A.V. Ramanan to elaborate on these aspects. And of course, it's very difficult to say whether it is mainly because of, even though they are Omicron positive, it is only because of Omicron or associated viral infections. We are not sure about it. So I request Professor Ramana to explain all these aspects. Second question I want to ask him is, should we have to test all the children when the child present with fever? We do not test the children when they present with fever because, of course, even if they are turned out to be positive, only by monitoring these kids, their vital signs and follow up only, we are going to decide whether they require hospitalization or not. In that situation, the testing does not make any big difference. So are we right in not testing children presenting with 2 or 3 days fever? Generally, we postpone it to 4th or 5th day. Again, request Professor Ramana whether it's a right practice to follow. And in children, USA, more children are vaccinated. India, children are unvaccinated except the recent few days. Do we expect Omicron to behave differently in India? And the last question is, when 2-dose vaccine could not stop Omicron, how do we expect the 3rd dose is going to stop Omicron or reduce the severity? And do we expect that because your team only presented the first cases of multiple system inflammatory syndrome, and later it took a different smart and shorter name as MISC. Do you think that MISC can occur or PIMS TS can occur in children who develop Omicron? These are all the questions come to our mind.
Thank you very much, Dr. Tangavelu. It's an absolute pleasure to see you and interact with you. We've liaised for a long time. So I'll answer the questions from the last question first, because I remember them. In terms of MIS-C, we think, yes, you will continue to see MIS-C. We are, and this is anecdotal evidence, so I don't want you to, we are seeing slightly younger children. Normally in the first two waves. MIS-C was more common in the 5 to 15 year age group. So initially it was the 10 to 15 and then 5 to 10. But we are seeing children more between 3 to 7 years of age. And it might be a reflection of the fact that the over 12s are more likely to be vaccinated, so less likely to have viral carriage and stimulation of the immune system. So can you see MIS-C with Omicron? The answer is yes. What proportion? I'm afraid I haven't got that data and I would not want to speculate. So that was one of your questions. In terms of booster is highly contentious and there are loads of cases for and against it. But the key argument for boosters that was promoted in September in Western world was there are two forms of immunity, as most of us will know. There is the immunity you can measure by looking at antibodies, which is your B-cell immunity, and the immunity which is harder to measure, which is your T-cell immunity. The B-cell immunity, which we measure using antibodies directed specifically at vaccination, clearly demonstrates that you start having decreasing antibody levels from about 3 months, and by 6 months you have very little. And in vitro studies in the lab show that even for the vaccine, so-called vaccine evading variant that Omicron is, if you have high levels of the antibodies, you are more likely to be able to neutralize the virus in vitro than if you had low titers of antibodies. Okay, it doesn't completely escape vaccine, it just has got some potential to evade. So the idea was that by using huge levels of antibodies, or essentially carpet bombing strategy, that was the logic for the booster. We will never know if the booster was required or not, because we'll have to wait for data from countries which haven't done booster to see if countries which have had a booster to countries which haven't had a booster have had similar rates. There is also greater concern in Europe and North America for giving booster because our proportion of elderly is much higher than the proportion of elderly populations in low and middle income countries. So there's greater anxiety. And I think the requirement for booster will still have to be one which will be debated. The first question you asked, the intensive care one, is very interesting because we have, every week we have a recovery pediatric steering committee, which has got a bunch of us, ID physicians, intensivists. And the intensivists have an ongoing, the pediatric critical care group in UK have an ongoing registry. There was a suggestion of increased admissions, but we are not clear if this was a true increase related to direct COVID-19 positivity, Omicron, or whether Omicron, because it's so prevalent in the community, a bit like the case you gave about steroid refractory nephrotic syndrome, whether it was an innocent passenger. And that granularity of whether Omicron fuels greater amount of intensive care admission in a tiny minority of children, or whether it's incidental, we'll have to wait and see. But it is clear that if you have comorbidities, then you may be more likely with these viral infections. And I lastly put something which may have escaped. We may focus so much on science that we sometimes don't focus on human behavior. Our ability to self-isolate and be strict with rules was far better in 2020 summer, slightly better in 2021 summer. Come January 2022, nobody, and none of us, me included, are capable of adhering to the strict, being in the keeping COVID appropriate behavior, as it's called. It is increasingly hard. And a lot of the immunosuppressed, those on immunosuppressive medication and those with morbidities were very careful for about 18 months, but they are slowly finding it harder and harder to be careful. And maybe it is more social behavior which is exposing this population, and that they would have always come into hospital if they get into some viral infection, and that Omicron is not any more of a danger to them than any other viral infection, which is always an issue in these populations. I hope I touched on 4 of the questions. I can't remember which question I haven't answered.
Thank you, sir. Only one question. Because all the US population children were immunized.
Yes.
But in India, they are not immunized. Do you think that Omicron will behave differently in India?
I don't, because the Indian pediatric scenario is similar to the UK. Our 12 to 18 were started vaccinating only in September. Under 12s are still not vaccinated. What we have found is a greater chance of these kids having 1 day of fever And the levels of hospitalization in different parts of the world is a reflection of anxiety and the individual healthcare systems and parental anxiety rather than actual need for hospitalizations would be my statement. And I think if you're vaccinated, maybe the chances of having carriage and transmissibility is slightly reduced. But I don't think the risk of hospitalization and illness is increased in those who are unvaccinated.
Thank you, sir. Now our governments are thinking of opening up the schools, because if we don't open the schools, children almost forgotten their school addresses. They don't remember the teachers. Many of them become obese, psychosocial issues, lot of problems staying at home. So probably the society has started thinking that Omicron time is the right time to open up the schools, because there is a time when probably when we are facing a least problematic viral infections, probably once it starts ending, that will be the right time to open up the schools, so that the child can resume their normal activities and then they escape from obesity and psychosocial issues. Probably we are waiting for that. How long generally the epidemic lasts?
Yeah, that's a great question, actually.
In the experience of US and South Africa and UK.
Yeah, in UK particularly, I can speak. Schools were the last to be shut and the first to be open. Exactly for the reasons you mentioned. I think we have deprived probably a generation of children from the educational opportunities and this huge psychosocial impact that not being in school is going to have. So in UK, throughout the entire 2 years, schools were shut only for a maximum of 8 weeks. And I think it's crucially important that children go back to school. And even in the unvaccinated scenario that we have, under 12 vaccines not offered in UK, while there have been outbreaks continuously in schools and children periodically having to stay at home when they get fevers, it hasn't resulted in a greater amount of illnesses that need hospitalization. Of course, it's going to provide an environment for transmission, but the disadvantages of that are far outweighed, exactly for the reasons you mentioned, by children going to school. It's crucially important, and I think it would be the right way forward that start of February, my personal view is they should go back to school. And we'll have to accept that that's going to provide a transmissible opportunity, but that's got to be managed with the help of governments and other sectors.
Time permit, there are some questions in the chat box. Please mention update about the neo-COVID infections. Neo-COVID infections too.
You mean, I presume they mean neonatal COVID?
Recently, yeah.
Is that about the new variant or the neonatal variant?
No, new variant. New variant.
The new
variant.
Well, we haven't.
No, the new variant people are talking about.
New variant.
New variant described in China.
Called a new COVID.
Few days back.
Labeled as.
Yeah, well, I can't give you an informed opinion because we haven't got sequencing data and enough information that I can tell you anything in a robust way. So I'm afraid I can't give you any qualified answers. So I would refrain.
Okay.
One of the participants is told that they have noticed more incidents of febrile seizures. Another participant requested question whether all children with suspected COVID should be tested for Omicron. Is it needed or not? This is the last question, Bala.
Yeah, the last one is a question you asked as well. And I think, I don't think you need to test every febrile child, but it depends on your local policies. The only reason for testing these children would be for self-isolation and preventing community transmission. But from a purely pediatric perspective, there's no need to go around testing every child with 1 or 2 or 3 days of fever. I don't think it's going to change management because it's still going to be simple principles of seeing how they are. So.
Thank you very much, sir. Thank you very much, Dr. SPS, for giving an opportunity.
Sir, excuse me, Thangvelu, sir. Can I ask a question?
Yes, Dr. Dhiren. Dr. SPS, sir. Dr. Dhiren wants to add another point.
Just, can I ask one question? What is the difference of antibody response as compared to Delta and this wave in pediatric as well as adult? What's the difference between the two? Because what we found in the Delta or the previous wave, most of the MISC patients did not have symptomatic disease, whether it's for Delta. I'm talking about pediatric. 75% of the pediatric patients who developed MISC did not have symptomatic disease, but lot of antibodies in them, right? So presently, you're witnessing this wave a month before we started witnessing, right? So this is the peak time of getting MISC. So did some study in some group of patients where you could find the seroconversion in pediatric age group? If you did, how it is different from the previous? And second one, which usually everybody is interested, is this Omicron is able to mount that immune response that we can save ourselves like a immune booster, and later on we don't need major vaccination for these patients to save us from Delta. We understand that in future, if similar waves comes, we are not scared. It will go like, it will come and go like influenza. But everybody is worried about the Delta sort of mutation if it is going to happen. So these are my two questions.
Both are great questions. I'll take the second one first. And I think that is the prevalent thinking that having exposure to the virus, what you call as natural immunity through Omicron or through Delta or through both, would highly likely confer a level of protection for the future waves. And as you say, it will become a bit like influenza, endemic in the population, and that in future variants, you might just get a milder illness. And I think that's the prevalent thinking. In terms of whether we are checking seroprevalence, and I'm sorry I rushed through a lot of those slides, the REACT study, which I showed, which took place between the 24th of December and the 12th of January, took 100,000 individuals, random sampling of PCR, which included children about the age of 5, and then genome sequenced all of them. So the two things that stood out from that community seroprevalence as well as actual sequencing of the variant was 99% of those who were positive were of the Omicron variant, and a significant proportion compared to Delta were children. So children are more likely, it might be, as I said, because of the vaccination, that they're not vaccinated, more likely to be mounting a response. In terms of antibody titers and so on, it's early days. We haven't done that level of analysis, but it will come. But the prevalent view is the one that you articulate, and we hope that this might confer a level of natural immunity for future variants. In terms of MIS-C, we continue to see them. Whether the proportion is more or not, we are doing a real-time surveillance. So that will take a few more months for us to see whether. One of the reasons why the MIS-C might be less is our thinking for MIS-C in children at the height of Delta waves was when there is a lot of COVID in the adults and there is repeat viral exposure, there is repeat stimulation through antigenic presentation again and again. Whereas now with Omicrons, with so many people being immunized, maybe the prolonged viremia that used to exist in the adults in the household is not. And that might be one contribution for why there may not be as much MIS-C. But we'll have to look at that data in more granularity as it becomes available over February and March.
Thank you.
Thanks, a fantastic session. Thank you, Dr. Ramanan. We'll take up some questions at the end of the 4 talks. Now, the next session is an epidemiological viewpoint of the present third wave. And we have a very distinguished speaker today to do that. That is then Dr. Manoj, ICMR based, he's an extremely distinguished, he's very well known for his surveillance studies on rubella, which are and in fact, he has been recently conducting a study on Zika. His studies research epidemiological surveillance of COVID Tamil Nadu, and he's an extremely thankful to him for accepting to spare his valuable time to talk to us on the third wave of COVID-19 in India and Tamil Nadu, an epidemiological review. And this session will be chaired by Professor Rema Chandramohan, who is the Director Professor of the Stanley Medical College Institute of Child Health. Over to Professor Rema Chandramohan for the next session, which will be for 25 minutes, followed by 5 to 10 minutes of question and answer.
Welcome.
Thank you.
Pleasure to have you as part of
Rema, please.
Panel, and we are looking very much forward to your views, and I think we will save the comments and the questions for the end. Please go on, sir.
Thank you very much, madam. Can you see my slides?
Yes, sir. Yes, sir.
And can you hear me well?
Yes, sir.
Okay. You can see you as well.
Yeah.
Yes, sir.
So first, at the outset, I want to thank Dr. Balasubramaniam for this invitation. And I'll be talking about the third wave in India as well as in Tamil Nadu, and give some epidemiological perspectives to the third wave. Well, this is the outline of my presentation. Initially, I'll talk about current evidence about Omicron, and there certainly would be some repetitions with what Dr. Ramanan, earlier speaker, talked about. And as you rightly mentioned, very little data is available which are peer reviewed, and most of the published literature is in preprint. And especially from India, there are only few papers on Omicron, mainly the lab related studies that were conducted by NIV. And then I will talk about the situation of Omicron in Tamil Nadu as well as in India. And finally, the most important is what are the future projections, and what would the Omicron wave, what would be the future projections, and what will be the herd immunity in following the Omicron wave. So to understand the epidemiology, I think there are some important evidences that I would review. And first is about transmission. We all know now that there is Omicron variant has a significant growth advantage. And in terms of two important indicators of transmission, one is the doubling time. This particular variant has a doubling time of as low as 2 days, which was found in UK studies, and about 3.5 days, which was found in studies in South Africa. And when we compare this doubling time against Delta, which has about 10 to 11 days of doubling time, you can imagine that how fast the epidemic would be, or how far the virus would spread in the community. The second important parameter of measuring transmission could be secondary attack rate. That is, what proportion of susceptible individuals would get disease or would get infection once exposed to the virus. So for the secondary attack rate for Delta was about 10 days, as compared to Omicron, it was about 14 days. And studies in Denmark had shown that the secondary attack rate was as high as 31% against 21% in case of Delta. So this transmission advantage which this variant has is mainly on account of its immune evasion capacity. It evades immunity that is acquired because of natural infection as well as because of vaccine-induced immunity. And the lab studies or animal studies also suggest that this virus particularly infects and multiplies in bronchus tissue faster than Delta as compared to the lung-derived cells. And because of this, there is a predominant viral replication in upper respiratory tract, which may confer at least some transmission advantage to this virus or to this variant. Second aspect, which I will talk briefly about, disease severity. And Dr. Ramanan talked about the 4 waves in South Africa, first by the ancestral Wuhan variant, second by Beta, Delta, and currently the Omicron variant. So these are reported number of cases, and compared to the reported number of cases, if you see reported number of deaths, There were substantially lower reported number of deaths in South Africa, again indicating that the disease has a less severe in nature. This table down shows outcomes of hospitalized patients in South Africa, and this is the data from private healthcare facilities in the country. And as you can see here, in first wave, about 80% of hospitalized patients required oxygen, as against 17% in the fourth wave, which was because of Omicron. Similarly, the need for mechanical ventilation was about 16% for first wave, about 12% for Delta wave, and it is less than 2% in case of Omicron. When you talk about mortality, the deaths, you can see that in Delta, during Delta variant as well as during Beta wave, about 25 to 29% of hospitalized patients died, as against 2% of hospitalized patients dying during fourth wave. Again, these findings indicate that Omicron causes less severe disease compared to earlier variants. And not only these studies, but there have been a number of studies now which are available in preprint, which indicates a lower severity, lower odds of severe disease that was reported in South African studies. The UK Health Security Agency's data indicate 47% reduction in risk of presentation to emergency care or hospital admission with Omicron as compared to Delta variant. And also in USA studies also indicate better clinical outcomes for Omicron patients as compared to Delta. And there was a substantial reduction in symptomatic hospitalization, admission to ICU, as well as mortality because of Omicron. This is the data of our studies conducted in Hong Kong, and this what these investigators found that this particular variant multiplies at least 70 times faster than Delta variant in human bronchus. And in this the first graph, you can see that they have considered three viruses. One was the original or ancestral virus, second was Delta variant, and third was Omicron. And compared to Delta, Omicron multiplied 70 times faster in human bronchus, and that is one of the reasons why most of the patients come up with upper respiratory tract infection and or upper respiratory symptoms, and also has a higher transmissibility of the virus. Then the second experiment was on lung tissue, and what they found that Omicron infection in lung is significantly lower than compared to original SARS-CoV-2, which also could be one reason why the disease severity is lower among patients who are infected with Omicron variant. The third thing I will also talk about the impact of Omicron on diagnostics and testing. This Omicron variant includes the parental B11529 variant, as well as several of its descendants, including BA.1, BA.2, and BA.3. Currently, BA.1 is predominant in most countries, including India. And this particular lineage, BA.1, has a deletion in spike protein, which results in S-gene target failure. So S-gene dropout or S-gene target failure is considered as important marker of Omicron, especially with BA.1 lineage. And WHO initially also suggested that this could be considered as a screening test for Omicron. But the subsequent lineages like BA.2 does not have this particular S-gene dropout. And therefore, if we are using only S-gene target failure as a criteria, we would be missing several BA.2 cases. The next important point which we need to understand is impact of Omicron infection on immunity. And there have been a number of studies which indicate that Omicron infection evades immunity, which is acquired by past infection, that is reinfection, causing reinfection, as well as immunity acquired because of vaccination. So if you see the reinfection risk because of Omicron, so there have been studies which indicated a substantial drop in neutralization of Omicron in convalescent sera, up to 20-fold drop in neutralization of Omicron among patients who were infected with earlier variants. The studies also have indicated that individuals who were previously infected, followed by 2 or 3 doses of vaccine, demonstrated 7-fold reduction. So among vaccinated and infected individuals, the reduction in neutralization may be less, but still such individuals will have a risk of reinfection. But very importantly, these studies documented well-preserved cell-mediated immunity, and that could be one of the reasons why we are not seeing a lot of deaths among patients who are infected with Omicron. And studies have indicated that about 5.4-fold higher risk of reinfection in patients infected with Omicron as compared to Delta variant. Now coming to immune evasion following vaccination, and this is measured in terms of vaccine effectiveness. So there are again number of studies which indicate lower vaccine effectiveness against symptomatic disease as compared to Delta, and this is the data from UK Health Security Agency. So here in the left-hand side graph, you can see the vaccine effectiveness against Delta, which is shown in dark squares, whereas vaccine effectiveness against Omicron, which is shown in gray circles. So as you can see, those individuals who had received 2 doses of Chadox vaccine, which is equivalent to Covishield in India, by about 20 weeks, the vaccine effectiveness against symptomatic disease come down to as low as 20%. For Delta, it was about 60% at that time. Addition of booster doses increased vaccine effectiveness, but it was always even, as you can see here, it was lower than Delta effectiveness against Delta, and it was ranging between anywhere between 40 to 60% at different time points after vaccination. The same is true for mRNA vaccines. Vaccine effectiveness is lower for Omicron as compared to Delta variant, and the booster doses increases vaccine effectiveness, but it is always lower than effectiveness against Delta. And it is always here in case of mRNA vaccine, it was in the range of about 65 to 70%. This study shows vaccine effectiveness against severe disease as measured by hospital admission. And this particular table shows that the vaccine effectiveness against hospital admission among individuals who had received first dose of vaccine 28 days after first dose was in fact didn't have any effectiveness with hazard ratio of 1.02. But if you see those individuals who had received 2 doses 14 days after 2 doses, the hazard ratio was 0.35, with indicating vaccine effectiveness of about 65%. And those who had received 3rd dose, the effectiveness against hospital admission was the hazard ratio was 0.19, and effectiveness of about 80%. So vaccine effectiveness against severe outcome are lower for Delta than lower for Omicron than Delta, but mostly remain greater than 50% after primary series, and they certainly improve after booster doses to over 80%. So this is the data from South Africa, and again, Dr. Ramanan showed some of these graphs. This shows incidence of COVID-19 by age group as well as by sex. And I'm really sorry for the quality of this figure, but as you can see here, the orange here, the lowest bar curve basically is the incidence for 0 to 4 age group, and 6 to 9 is after that. And highest incidence was in the age group of about 40 to 59. And this was basically a pattern for all the waves. And so the higher incidence was there in middle and elder age group, and children had a comparatively lower incidence, even in Omicron wave as well as in earlier waves. And there was not much appreciable difference of incidence by gender, by sex. With this background, I'll talk briefly about the situation of COVID-19 third wave in India. And so these two graphs shows the reported number of COVID cases, not deaths, in India and Tamil Nadu. And since last about 2 months, India is seeing the upsurge of COVID-19 cases, and the test positivity as high as 25% is reported in different states. Several people argue that this reported number of cases are not representative of actual situation in the country. And this could be because of several reasons. First is the change in testing strategy for the third wave that I will talk about shortly. And also one important reason why these numbers are not representative is that many infections are asymptomatic in nature or mild in nature, and the testing doesn't happen. Many people test using tests which are purchased over the counter and which are not accounted for, and that could be that may be the reason why reported number these curves may not reflect the reported number. But these curves definitely indicate what is the trend of or how the epidemic curve is behaving in the country, and what is the status of the pandemic in the country. We also know that from 10th of this month, third dose of COVID-19, the preventive dose of COVID-19 vaccination began in India, primarily targeting for healthcare workers and elderly people who had comorbidities. And we know that this booster vaccination or third dose is not going to anyway influence the third wave, and that we are seeing increasing number of cases. So, but certainly this third dose will be useful for those immunocompromised patients or those patients who did not mount immunity with the 2 doses. Although we are seeing increase in the last at least a week or 10 days, we are seeing plateauing of curve at a national level as well as in Tamil Nadu. And the lower curve, lower graph, you can see that the cases are in fact declining. Although this may be too early to say that that they will come down, but going by the situation that happened in other countries, we hope to see the decline or decline in number of cases or declining or decreasing trend in coming days. Although the disease Omicron causes a mild disease, it also causes death, and you can see the number of deaths that were reported in India. But very importantly, the number of deaths that were reported in India as well as in Tamil Nadu have been much lower than that were reported during the Delta wave. Tamil Nadu, for example, is reporting about 50 deaths per day, whereas country is reporting about between 450 to 500 deaths per day. And again, there's no published data to this effect, but whatever preliminary analysis that has been done, findings indicate that most of the deaths occur among individuals who were unvaccinated and individuals who had comorbidity or had some immunocompromised status. And many of these deaths also were, Omicron infection was also incidentally detected among patients who were admitted for other serious diseases. When a disease is such a mild disease or less severe disease, hospitalization could be a better indicator to find out the trajectory of that particular COVID-19. Unfortunately, in India, we don't have data about hospitalization or trend of hospitalization at the national level. But in Tamil Nadu, we have been basically providing this data about bed occupancy, and several states provide such data, but at national level, this is not compiled or analyzed in a routine way. So this is data till 16th of January, and as you can see here, it talks basically about bed occupancy for non-oxygen beds, oxygen beds, and ICU beds. And you can see here like about the bed non-oxygen bed occupancy was about 12% till 16 January, and oxygen bed as well as ICU bed occupancy was less than 4% or about less than 5%. Again, indicating that bed occupancy has remained very low, third wave, and compared to Delta variant, where bed occupancy was nearly 100% for all three types of beds. This again indicating a less severe course of Omicron wave. This is the data from Mumbai, which talks about percentage of share of oxygen beds, ICU beds, and ventilator beds in Mumbai. And as you can see here, during Delta wave, about 100% of oxygen beds, ICU beds, as well as ventilator beds were occupied. Whereas you can see now during Omicron wave, less than 40% of ventilator beds are occupied, less than 20% of oxygen beds are occupied in the city. About the testing strategy, I told, since the disease has a milder course, ICMR and the National Task Force revised the testing strategy a few weeks back. And the objective of this strategy is to early detect symptomatic cases for early quick isolation and also for their management. And early detection of infection in elderly people and individuals with comorbidity. So these are the two important objectives of current testing strategy. And again, this time, besides the molecular tests, which are routinely or which are very conventionally used for testing, home care tests are also promoted by Government of India for testing, again considering the milder nature of the disease. So current testing strategy in community setting includes testing of symptomatic individuals, and this is in sharp difference with the Delta, when there was a Delta wave where both symptomatic as well as asymptomatic contacts of COVID-19 patients were tested. Here, the testing strategy only recommends testing of individuals who have symptoms and testing of contacts who are elderly, more than 60 years of age, and who have comorbidity. Only those should be tested. The third group which is recommended for testing is individuals who are undertaking international travel, and this is primarily because of requirement of those countries where the Indian passengers are going abroad. But the last point is international travelers arriving in India, and again, I have my own opinion whether it has any value in preventing the further transmission of Omicron in the country, especially when the virus is already in community transmission mode. In hospital setting, the recommendation mentions that this is at the discretion of doctors, and it clearly mentions that no emergency procedures should be delayed for want of or for lack of test results. So the guideline clearly specifies that who should not be tested, and this includes the asymptomatic individuals in community settings and contacts of confirmed cases, unless they are identified as high risk, that is elderly people and have comorbidities. And again, those who are discharged from hospital or home isolation should not be again tested to find out if they are negative. And interstate travel, again, we know that following the initial reports of Omicron in South Africa, several states imposed a requirement for test negative certificate for interstate travel. So ICMR and national guideline clearly indicates that there is no such need for having a test negative certificate for interstate travel. We have a limited data about genome sequencing, but we all know that INSACOG has been generating data about the sequencing. And the last INSACOG bulletin, which is published on 7th of December, basically 10th of December, indicates that Omicron is currently in community transmission mode. Unfortunately, the report doesn't specify that what proportion of total COVID-19 cases that they have sequenced are because of Omicron and what are because of Delta. This report also clearly mentions that there is the substantial proportion of cases are because of BA12 lineage besides BA1 lineage. And we know that BA12 lineage will not have S-gene dropout characteristic. And therefore, if we are going by S-gene dropout as a criteria for diagnosing Omicron, we would be missing several cases. I'll now talk about the COVID-19 projections in India. And there have been a few models about COVID-19 projections. This is a model that has been developed by ISI Bangalore, and I thought it reflects the current situation very correctly. So the modelers use three scenarios: 30% immune escape, 60% immune escapes, and 100% immune escape. And based on this model and using the South African data in the background, they constructed as to what would be the trajectory or what would be the projection of COVID-19 cases at national level. And similar data is also available for each state. So and in the red, in the red graph indicates the reported number of cases in India, and which follow very closely with the 30% susceptible or 30% immune escape. So these projections indicate that COVID-19 cases would come down by end of next month, that is end of February. And as we are also seeing, the decline has already been seen. The plateauing of COVID-19 cases are seen both in state as well as nationally, and states like Delhi as well as cities like Mumbai are reporting substantial decline in number of cases compared to the last 2-3 weeks. One important point, or it was also asked, this question was asked by one of the speakers as to how is the immunity following Omicron infection. And there have been few studies wherein they have studied the immunity following Omicron infection, and these studies indicate that Omicron infection enhances neutralizing immunity against Delta variant. And in this particular experiment, they have taken 3 groups of patients. One was patients, the patients who had Omicron. Their sample were collected, and follow-up sample was collected 14 days after their baseline sample. And these patients included patients who had received vaccine, unvaccinated and unvaccinated patients. And as you can see that the neutralizing antibodies against Omicron increased by about 14-fold after infection, and by about 4-fold against Delta variant. So again, there was increase in neutralizing antibody against both Omicron as well as Delta, and although the increase was less for Delta variant. And if you further see, and I'll show you further slides, this increase was higher among those individuals which had received vaccine as compared to those who were unvaccinated. This particular study shows that Omicron infection in vaccinated individuals enhances neutralizing immunity against Delta variant. Again, here the first graph shows Omicron immunity against Omicron virus over a period of time, and the second graph indicates immunity against Delta variant. So you can see that compared to unvaccinated individuals, where the increase was 4.4-fold against Omicron variant, among vaccinated, this increase was about 14-fold. And against Delta, this increase was 6.1-fold in vaccinated individuals as against 5-fold in unvaccinated individuals. So this, there's one more study basically which indicates that SARS-CoV-2 breakthrough infection, that is infection in vaccinated individuals, elicits potent, broad, and durable and neutralizing antibody responses, both against against Delta as well as the Omicron variant. And these are very important findings when we talk about potential future wave, because we know that because of Omicron, a large proportion of people would have been naturally infected, and this immunity will be against different variants besides other variants besides Omicron. So just to summarize, the third wave in India is primarily driven by Omicron. Hospitalization and death rates are lower compared to the second wave. And this Omicron wave is expected to achieve a substantial herd immunity level in the country. And this is especially against the background of high seroprevalence in the country. We had more than 70% prevalence by July last year. And the coverage of 2 doses, we know that about 65% of India's adult population have received 2 doses. And these antibody responses are expected to be broad and also durable. Thank you very much, and we'll be happy to take any questions.
Over to Professor Ramachandran Mohan, please.
That was an excellent talk, Dr. Manoj. You brought all the evidence right onto our table, and we have learned a few facts. We realized that the immune evasion of the Omicron is what is responsible. And of course, the localization in the pharynx. We've seen all these patients presenting with typical symptoms with the sore throat and then a fever and then a myalgia. And as a previous speaker said, in children, it just passes off like that. So most of them are not even tested. And even a 1-day fever, none of us are testing those children. And except, of course, when they have comorbids and when they are taken up for surgery, that's when we are doing the testing. So there are some questions in the chat box. Before that, I would like to know whether, because a lot of people have gone through the symptoms, they're wondering whether they should have an antibody testing done before they take up the booster dose, or whether they can go ahead and take the booster dose. And if they are planning a booster dose, whether they should wait for these 3 months after this infection. And the second is, many of them have not really bothered to test, because once the symptoms had come, they have just assumed that it is this Omicron infection. So what is the, what should they do regarding the booster dose?
Yeah. So thank you, madam, for this question. First was about whether they should test for antibodies before taking booster. So they should certainly not test for antibodies, because that is not going to tell you. Antibodies are most of the people who had Omicron infection are going to be positive for antibodies. So there is no point testing for antibodies and finding out what is your score, how much is the level. The guideline, vaccination guideline clearly indicates that if you had a lab confirmed Omicron infection, you should delay your booster for 3 months, primarily because it will have better effect when you receive vaccine at 3 months. Because if once you have infection right now and if you take vaccine immediately, it may not have or it may not add anything to the already acquired immunity. So it is always better to delay the vaccine by 3 months. And we have seen that antibodies decline by start declining after 3 months. So there is no point testing for that, and one should delay the booster at least by 3 months. The testing guidelines are very clear that people who have symptomatic only should be tested. Those who do not have symptoms should not be tested. And we know that in fact, many of us had a mild symptom and we thought it is just cold, let us not test it.
Yes.
But if you have particularly, some elderly people in the family and some comorbid persons in the family, it is always better to do testing. And testing is primarily for to isolate yourself, and also if somebody has a comorbid condition, his care can be immediately done. He appropriately be hospitalized if he has a comorbid condition.
And regarding this home testing that are available in the pharmacies, will that be also added to the number of positives shown by?
No, actually, that is what I was telling. This number of cases that are reported nationally and in the state only talks about patients who underwent testing using ICMR SRF-ID. So, so when a patient is tested and ICMR SRF-ID is generated, only those numbers are counted. I mean, those who come positive are counted. But those who buy kit or pharmacy in pharmacy, they are not. I mean, there is a provision to update this data in ICMR portal, but we know that most of the people don't do that. They do the test. It is a very simple test. 10 minutes, you will have the result, and they don't. And this is not updated basically, and that's why the number that we are seeing every day may not really reflect actual situation. But it doesn't matter. It gives us a trend. Where are we going? Whether we are on upstream or going down.
Yes, and 70% herd immunity is protective, isn't it? And we can look forward to the end of the pandemic probably in a month's time.
I mean, end of third wave certainly, but we can't really say end of the pandemic because when the Delta wave came down and when we found 70% people already were having antibodies, vaccination was already on. We thought we may not have another wave, but if an immune escape variant comes like Omicron, we will have certainly. Same way now, if we have another variant which escapes all the immunity, doesn't respect any immunity acquired by Omicron, or we may have more cases. But like what we are seeing here, we don't expect that the variant will have very high mortality, very have severe disease.
Yes, sir. And higher the doses of vaccination is going to give us.
Exactly. Yeah. And that the studies have shown that higher the exposure to virus, either through natural infection or vaccination, it will have a broad immune response against Delta, against Omicron, all variants.
Yes, sir.
That is a good thing. I mean, a positive thing that this is a mild infection spreading fast. Many people are getting infection,
yes,
and they will have immunity, naturally acquired immunity.
Yes, sir. So there are a few questions in the chat box. Dr. Nedunjerian sir has asked, are there any studies on the seroconversion rate and sustenance of the titer over time following immunization first and second dose and natural disease in India or Tamil Nadu? If available, what are the observations?
Yeah, so several, I mean, I can talk about one study which is conducted by NIRT, National Institute of Research in TB and NI. So all people who got vaccinated, all the staff members who got vaccinated on 16th of January 2021, they are being followed up, and they have seen both humoral as well as cellular immune response following vaccination, and it clearly indicates that most of the people became seronegative by about 7 months. So there are, I mean, ICMR is planning a similar study after booster vaccination, developing a cohort of people who have received booster vaccination.
Dr. Manoj, I am Dr. Dhiren. Can I ask Rima ma'am?
Yes,
can
please.
I ask directly?
Yes, sir. Please, sir.
Sorry, I missed. You know, most of the studies says that by 6 months you become seronegative. So for a human being, you require good amount of antibodies to prevent asymptomatic disease, and you require some amount of antibodies with good T cells to prevent life-threatening disease. WHO explain any benefit of taking any vaccination is when you have symptomatic benefit in more than 50% of the patient. This is the definition of a good vaccine, which has to be approved by WHO. Now, first of all, why our policy is to take vaccine after 9 months, not 6 months. One, though you remember initial part, we health worker, we had less gap of Covishield, which was not recommended. It should have been 12 weeks for best of the benefit. So why it was 9 months? We were fortunate enough to have mild Omicron. If it would have been Delta-like, then probably it was the wrong time and the wrong decision at the wrong gap. So that was my thinking. Now regarding the future vaccination, suppose I got symptoms, but I did not test it myself. I'm not sure whether I had the present infection or not, that is Omicron. When I should take booster and which booster I should take? That is the maximum question which is troubling the health worker. So if I am not sure about my status, whether I have acquired Omicron or not, should I get antibodies in next 2 weeks? suppose I don't have a good amount of antibody, so I'm sure that I did not acquire Omicron, so I will get my booster right now rather than delaying for 3 months. Now, last point is that suppose I have taken booster, I did not acquire Omicron, or if I delay my vaccination, not 3 months or 4 months or 5 months, I just anticipate the next COVID wave which is going to strike us a month before if I take that vaccination. Do you feel that is the best period to have best of the symptomatic benefit to for that vaccination? Because you don't know that if you get a Novavax as a vaccine available, and we know that Covo Boost has given the best response to the Novavax other than mRNA. So these are my some queries.
Yeah. So thank you very much, sir, for these questions. First, we know that all the vaccine that we are using, their immunity, I mean, their effectiveness against symptomatic infection is much lower, and their main benefit is that effectiveness against severe disease, hospitalization and mortality is much higher as compared to symptomatic disease. The second, and that is why even those individuals who had received 1 dose or even 2 doses, the mortality is much lower. They may get symptomatic infection, they may get infection, but they may not develop severe disease. Second point is whether why vaccination booster dose after 3rd dose. So when this issue was discussed, I mean, we know that several developed countries are giving 3rd dose. Some countries are also giving 4th dose. And despite that, they are getting, there was an Omicron wave. I mean, even all the countries which had booster vaccination, there was Omicron wave. Now, India, when we had Delta wave, a large number of individuals got a natural infection, either subclinical or clinical infection. And the seroprevalence at that time was about among unvaccinated was about 60%. It was sometime in June, and after that also cases were occurring. So and then so basically people already had one infection, and after that people already got vaccination, 2 doses of vaccination, which essentially means people got 3 exposures to the virus. So which was basically like a booster dose. So whether we really needed that vaccination at that time, booster dose, is a question mark. And what is the benefit that we will, unless we really see what was the benefit of giving this precautionary dose now, that one has to really study. But yes, those individuals who are immunocompromised, those individuals who are elderly, where their immunity has come down, such preventive doses will be certainly useful. In healthcare workers, giving additional dose after 4 months, and when you are suspecting that a new wave is coming, I really don't think so, because we know that antibodies come down over a period of time, and we really should not be guided by the antibody presence or absence of antibodies. It is a cell-mediated immunity. There are memory cells which in case of exposure to the virus, mount antibody response. That is what one should believe in, and one should rely on. And that's why we are seeing, I mean, even in case of Omicron, I mean, people who we are seeing very low mortality. Same was in case of Delta. People who were vaccinated had much lower mortality compared to unvaccinated individuals.
Yeah, Dr. Manoj, just one.
Yes,
I just want to counter a question.
Dr. Dhiren, we'll take up the questions at the end. We'll take up the questions.
Okay, sir. Okay. Okay.
Last point which you mentioned, sir, was homologous and which vaccine they should give. I mean, there are a number of studies which indicate that heterologous vaccination is much more immunogenic, is much better as compared to homologous vaccination. And and several countries also are recommending or giving that. The trial for heterologous vaccination is currently ongoing at CMC. And once these results are available, I'm sure there would be rethinking of this recommendation of giving homologous 3rd dose.
Yes, sir.
Okay. Thank you, Dr. Emma Chandramohan. We'll wind up the session and we'll take up. I know there will be a lot of questions to Dr. Manoj at the end. We have another last 20 minutes. We'll definitely direct all those difficult questions to Dr. Manoj. Over to Dr. Professor Balashankar, who's the Director Professor of Madurai Medical College, who's the chairperson for the next session. Of course, Dr. Balashankar is so well known, I don't have to introduce him specifically. Over to Dr. Balashankar.
Thank you very much, sir, for giving me this opportunity, and thank IAP Tamil Nadu branch for giving me this opportunity. We are in the mid, or what I can say, at the end of the third wave, which is caused by Omicron variant of COVID-19, which is supposed to be highly infectious, 3 times more infectious than the other forms, but fortunately a milder variant, which is occurring and sweeping India now. And we are in a peculiar situation where majority of the adults are vaccinated, and none of our children, especially those who are less than 15 years, are not vaccinated. So they are the one who are likely to be infected. Though we claim that Omicron is a milder disease, our children are less severely affected during this virus epidemic by this Omicron variant. That is one. Whether the symptoms are milder in children as in case of any other variant of COVID in this wave, especially in a scenario where adults are immunized and children are not immunized. That is one. Then, is there any variation in clinical symptoms of this Omicron virus than the other variants like Delta and all those things? That is it. And is there any difference in mode of diagnosis of this Omicron? And do we have any change in the management guidelines as far as this Omicron wave is concerned, especially in children? For example, as I know in adults, this antibody cocktail is not supposed to be very useful in this Omicron variant. Is there anything like that in children also, so that we have to change our management strategy? And of course, the MIS-C, what is it going to be following this Omicron? As more and more younger children are affected, are we going to get more and more younger children with MIS-C, and is there going to be any difference in clinical feature or management of MIS-C? We have the expert, the real expert, Dr. Balasubramaniam sir, who is a well-versed infectious disease specialist all over India, who will be able to answer these queries who are occurring in our mind. Over to you, sir. We expect a great lecture from you.
Thank you, Professor Balashankar. At the outset, I thank the IAP TNSC, particularly the Secretary, Dr. Rajendran, for the opportunity to discuss a very difficult problem. What is the difficulty? The practical issues for the pediatric practitioner because of this Omicron variant. The focus in my 25-minute session would be, what is the pediatric perspective of the third wave from the Indian point of view? And of course, I would be sharing some personal data from our institution so far over the last 3 years on COVID-19 and MIS-C. And then I will deal with some of the common questions that are often asked by my colleagues, by my students, with regard to management, diagnosis of this third wave. And I would give some suggestions for the right approach to answer those questions. We all know we are going through the third wave, and which epidemiologists like Dr. Murahekar has clearly shown that it is due to Omicron. What we have seen is that the number of cases of children who are going to get infected, symptomatic or asymptomatic, with Omicron will be higher. Definitely, yes. And most centers across the world have reported more hospitalization in older children I don't know whether that is still happening in India. It doesn't seem to be happening, but it's too early at this point of time. The scenario is not very clear. It has not unfolded in the full form, particularly the pediatric COVID third wave. What we have seen is that in the last 1 month, we have seen that it is affecting all ages from newborn to adolescents up to 18 years of age. Maybe because in India, the vaccination has been started only for above 15 years of age. And we have not seen higher mortality rates so far, though official figures are unavailable. But the mortality, I'm afraid, even among adults is low, and it's very low in pediatrics. Now, as of now, we have a few questions with regard to the pediatric perspective. Are we going to see more pediatric COVID cases? The answer is yes. Many of them are going to be mildly symptomatic and not severely symptomatic. The numbers will be large. But it's not going to challenge our health system. That's what we were worried about when the second wave occurred. Are we going to see more severe cases? Early days, there is a suggestion that we are not likely to see more severe cases, unlike the USA. As Professor Ramanan pointed out, we are going to probably follow the South African pattern rather than the US pattern with regard to the third wave. The third question is, are we going to see more MIS-C? That's $1 million question. At this point of time, the answer is we do not know, but there are indications that the number of MIS-Cs following Omicron could be lower than following the Delta wave or the first wave. In fact, in one of the publications from the South African perspective, had shown out of around 2,550 cases of pediatric COVID, there are only 4 deaths, not a single case of MIS-C. That is very reassuring, but it is too early because there is a latent period of 2 to 6 weeks following COVID-19, MIS-C occurs. So we'll have to wait and watch. Preliminary data suggests there might be less MIS-C following Omicron than following Delta wave. What about data from KKCTH? Over the last 2 years, from January, February 2020, when we reported the first case of MIS-C in March 2020, till 26 January, this is the data. What does it show? Like the second wave, the third wave, we are seeing increase in the number of cases. We have had nearly around 52 children with COVID positivity, most of them asymptomatic, very few mildly symptomatic. And so far, we have not had a single child with severe COVID or moderate COVID over the last 1 month. That is reassuring, indicating that Omicron, unlike the Delta wave, where we had seen quite a few severe and moderately severe cases, we are going to probably see less Omicron cases. What about MIS-C? MIS-C in the first wave, the numbers were less. In the second wave, the numbers had gone up. And so far in our institution, we have seen around 200 cases of MIS-C. And with the onset of Omicron, we are just seeing a trickle. Only 3 cases we have seen in the last 6 weeks. And in one of the cases, to our surprise, we did the genomic analysis. That child was PCR positive, had classical features of MIS-C. And we could prove by genomic sequencing that it is due to Omicron. And we have seen already the first case of Omicron-induced MIS-C. Hopefully, we won't see more cases in the future. With regard to deaths, we have seen 329 cases. We have had only 2 deaths so far. And in both those cases, Omicron was a bystander rather than the causative agent for death. One child had leukemia, had multi-organ dysfunction, who had incidental COVID positivity. Another child had a renal disease and had comorbid COVID-19. All other children, including those 200 cases of MIS-C, 177 in this figure, it's approximately 200, there have been no mortality. That is positive news for us. Next, what I'm going to do is to take up some questions which often practitioners and students ask pediatricians, senior pediatricians. Let us get on with these questions. This is frequent in these days of teleconsult. Every day I get a call. Father is tested positive, sir. My child is well. I'm worried. She wants to know whether testing is required or not. And she invariably tells me, my husband has been prescribed azithromycin and doxycycline and a few cough syrups, etc., vitamins. Do I give anything? The answer is very straightforward. Now that the ICMR has revised the guidelines for the testing, what does it say? If an individual is asymptomatic in a community setting, you don't have to test it. The answer is, we don't have to test the child unless the child has got some high risk condition. There's no point. Father is positive. What we have to tell them, please keep this child away from the elderly and follow the isolation guidelines unless the person is going to travel, in which case you're going to tell them don't travel for 1 week. There is no need for testing. Straightforward answer we can give, and we can tell them don't do the antigen test, don't do the PCR. Even if it is mildly symptomatic, there is no need to do. Somebody has put in the chat box febrile seizures. In fact, people are reporting many children with febrile seizures are having COVID positivity. Is COVID-19 the etiology for this febrile seizures? I don't think so. Is COVID testing mandatory in such a child? And what are the indications for testing? Here again, ICMR clearly says, in the community setting, if somebody is symptomatic, cough, fever, sore throat, loss of taste or smell and breathlessness, yes, you do. Somebody is going to travel, you do. Somebody is elderly, you do. Somebody has got a medical condition, which is one of the risk factors for severe COVID, you do. Otherwise, there is absolutely no need to test at all. I don't think we need to test all children with febrile seizures with COVID-19 routinely. We have to follow the precautions. And if you decide to test, what test do you do? Now that home antigen tests are available, even if you don't want the parents to do, they will do, and they'll tell you the test is negative or positive. And the ICMR has suggested that antigen testing can be done, though the government of Tamil Nadu, for reasons known to them, has not recommended home testing or antigen testing. But then in practice, all you have to tell them, if the child is mildly symptomatic, there is absolutely no need for testing. Keep the child away from the grandparents. And if at all they want to test quickly, they can do the TrueNAT testing or the gene expert or the RT-PCR. All of them are useful. And if they have facility to do rapid antigen test, they don't want to move out, they can do it, but it is not required at all. The ICMR algorithm suggests that if the home test is positive, it is positive. You don't have to do PCR. You have to inform the health authorities. If the home test is negative, the child is really having severe symptoms, then perhaps you have to consider confirmation with RT-PCR for epidemiological reasons. 6 months old infant is seen in the OPD with bilious vomiting. Ultrasound suggests a volvulus or intussusception. Somebody wants to do surgery. Do you do COVID PCR? No symptoms of fever, no symptoms of COVID-19. Here again, ICMR has come out with clear guidelines. No emergency procedure should be delayed for lack of test. There's no point in doing. You should take precaution. It is like HIV. Any patient a surgeon or a radiologist is going to handle might be HIV positive or HPSAG positive. You have to take universal precautions. You have to take precautions, and there is no need to do testing routinely for these procedures or for anesthesia in an emergency, or even if it is an elective procedure. Having said this, you have a child who has been found to be having confirmed COVID. The parents have done the rapid antigen test. The parents have done the PCR. They are asking you, doctor, are any investigations required? In fact, somebody had put in the chat box a question, what is the usefulness of CRP in a child with confirmed COVID? Let us take this question, and some of the guidelines which I'm going to quote now are from the recent updated guidelines from the Director General of Health Services, updated on 17 January 2022. They have modified the earlier recommendations, and they have suggested that there are no investigations which are required for any child with asymptomatic or mild COVID. You don't have to do any test. CRP is useless in mild COVID. But if a child has got moderate COVID, when I say moderate COVID, it indicates that the child has got severe pneumonia. It's almost equivalent to the child having fast breathing without severe hypoxia. That is moderate COVID. In such a case, the recommendations are to do complete blood counts, which may show neutropenia and perhaps, neutrophilia and perhaps lymphocytopenia. And you may get elevated CRP levels. You may get elevated ESR. And if you are looking for evidence of MIS-C, these two investigations along with CBC will be helpful. Blood sugar is recommended in moderate COVID, and an X-ray is indicated only for moderate COVID, mostly to look for signs of pneumonia or comorbid pneumonia. On the other hand, if a child has got severe COVID, the DCGI guidelines suggest that you should do liver function tests, which may give you clues of multi-organ dysfunction, renal function tests, which may give clues to hyponatremia as evidence of MIS-C, and LFT may show hypoalbuminemia, which may suggest it could be MIS-C. You can consider ferritin or D-dimer if there is high risk of a possibility of macrophage activation syndrome, as suggested by pancytopenia in the complete blood count. And if you are dealing with a high-risk case of severe COVID in the ICU, you can consider doing D-dimer. What about CT thorax? Absolutely not required. Unlike the adult COVID, where people get CT done the moment they get a PCR done and grading is done. This is absolutely not required. Even a chest X-ray is not required for mild COVID. Why CT thorax for a mild or moderate COVID? On the other hand, if you have suspicion of an alternative diagnosis, like for example, tuberculosis or an empyema or a pneumonia with complicated pneumonia, parapneumonic effusion, of course, you are justified in doing an ultrasound thorax and a CT thorax, or when there is no improvement in respiratory status, giving oxygen and respiratory support, child doesn't improve, you can consider CT thorax. The next burning question, remdesivir, molnupiravir, antibody cocktail, lopinavir, so many antiviral drugs are being talked about. They are being used in adults. Are they of any use in pediatric COVID? Here again, the DCGI guidelines have come out with a clear statement. What does it say? There is no safety data, there is no efficacy data. So remdesivir, favipiravir, molnupiravir, fluvoxamine, and even the antibody cocktail, which is widely being used in adults. Some scientists even call it as unethical, unscientific, but it's going on. And the DCGI guidelines have come out with a clear statement. They are not recommended for children less than 18 years of age, irrespective of the severity of illness. Whereas the DCGI guidelines say, don't worry about giving antiviral drugs or monoclonal antibodies. Please worry about treating the underlying comorbidity like diabetes, renal failure, underlying cardiac disease, underlying metabolic disorder, underlying malnutrition. Treat that appropriately rather than concentrate on giving these medications. And use of antivirals or monoclonal antibodies is not recommended as of now, as per the latest Indian guidelines. Let us take on another question. this is a question regarding comorbidities. Here is a child who has lymphoma and is on chemotherapy. High risk. Will monoclonal antibodies help? And if monoclonal antibodies are to be given, do you do genomic sequencing? Because there are questions about the utility of monoclonal antibodies in Omicron. And you find it is Delta, you give monoclonal antibody. You find it is Omicron, you don't give a monoclonal antibody. What does the literature say? Studies have shown that both against Delta and Omicron, these cocktails are not effective. There is not much hard data to support the use of this even in children with lymphoma. Of course, consideration for use of remdesivir has been there. You can consider it on a case-to-case basis. But then, this is the DCGI guideline, but what does UpToDate say based on literature search? Despite the unproven benefits, we suggest antiviral therapy with documented severe or critical COVID-19. And I'm afraid people will be tempted or compelled to give remdesivir. And this decision is to be taken with the consultation from an expert rather than a harsh, rapid decision. The next question that comes, most adults with COVID-19, they are prescribed antibiotics. And do we give antibiotics to COVID, pediatric COVID, and MIS-C? Since it is often difficult to distinguish bacterial infections from moderate or severe COVID and MIS-C, how do you handle this? The DCGI guidelines again have come out with very clear data. What does it say? COVID-19 is virus and it's not going to respond to antimicrobials. Certainly, there is no role for asymptomatic and mild cases. But on the other hand, if you have a child who has what looks like a moderate COVID and who has pneumonia, who has dysentery, who has sepsis-like features, definitely antimicrobials should be considered. Similarly, if there is septic shock in moderate or severe COVID, it becomes severe COVID, obviously, empirical antimicrobials based on cultures should be started. You should take a culture and start, and decision should be taken on local epidemiology, patient host factors, and the policy in your hospital, and also shrewd clinical judgment. What about anticoagulants? Somebody does D-dimer, the D-dimers are sky high. Straight away, do you start low molecular weight heparin? Somebody has been diagnosed as MIS-C, do you straight away start anticoagulants? What is the right approach? Here again, the DCGI guidelines say anticoagulants are not indicated routinely. I would say they are not indicated routinely even if the D-dimers are 10,000. However, every child who has moderate or severe COVID or MIS-C should be evaluated for risk of developing thrombosis and should be monitored for thrombosis. In a few situations where there is a strong family history or personal history of venous thromboembolism, or you have an indwelling central venous line, or risk factors, 4 or more without central venous line and 2 or more with central venous line. What are those risk factors? First degree relative thromboembolism, personal history of thromboembolism, decreased mobility from baseline, burns, active malignancy, estrogen therapy, not much in pediatrics, flare of an inflammatory disease like rheumatoid arthritis or SLE, morbid obesity, severe dehydration, recent surgery or trauma, definitely you should consider anticoagulant. And the best anticoagulant is low molecular weight heparin, 0.5 milligram per kg BD, and it should be given till discharge. And if there is thrombosis, it should be continued. However, in all cases of proven or diagnosed MIS-C, even if the D-dimers are normal, you should give aspirin 3 to 5 milligram per kg with a maximum dose of 75 for up to 6 weeks until you are sure the 6 weeks echo is normal. Of course, you don't give it if the platelet count is less than 80,000. What about high-risk groups for COVID? You are worried about, you want to admit, you want to consider giving antiviral drugs. Here again, a whole lot of medical conditions, starting with cancer, obesity, diabetes mellitus, etc. It is called in up-to-date medical complexity. If any of this is there, you should consider hospitalization, testing, and consider antiviral drugs like remdesivir if there is moderate or severe COVID. Coming to the vaccination, this which has already been discussed eloquently by Dr. Manoj, we often come across parents who ask us, sir, 15-year-old, last week he had COVID, he is now 15 years old. When do I give him vaccination? The best is to wait for 3 months. Best is to wait for 3 months, though the Indian government guidelines say you can give as early as 2 weeks. The WHO says you can give after 4 weeks. But I would suggest, since a natural infection is going to confer significant immunity, it would be wise to wait for 3 months before starting the vaccination. What about MIS-C mimics? We are coming across quite a few children who are initially thought to have MIS-C. Later, they turn out to have non-MIS-C. Let me share some data from our own hospital. We compared the profile of children whom initially we thought these children had MIS-C, and compared them with those who had MIS-C confirmed. We had a total of 135 cases, out of which 64 had proven MIS-C, 71 had MIS-C mimics. And what are those mimics? Appendicitis, dengue, enteric fever, scrub typhus, and viral illness. These constituted the MIS-C mimic. They behaved like MIS-C with elevated CRP and total count elevation. And these children had features like this. Look at this, dengue-like rash. Look at this, vesicular eruptions in the palms and soles. Look at this cervical adenitis, which is actually, we thought it is KD, it turned out to be suppurative adenitis. Look at this hand, foot, mouth disease, behaving like MIS-C with high fever. What did we find? We found if there is hepatosplenomegaly, if there is leukopenia, if the CRP is less than 100, MIS-C is unlikely, MIS-C mimic is more likely. And if there is shock, if there is rash, if there is LV dysfunction, it is more likely to be MIS-C. This is what we found. And in fact, I'm quoting one letter to the editor in the Archives of Disease of Children. What did they write? They said that it is time for us to omit antibody testing as one of the criteria for MIS-C, because 80% of the population are going to have antibodies. That should not be the basis for diagnosis of MIS-C. I am sure it will go out from the diagnostic criteria for MIS-C very soon. How about steroid use? There is a tendency to give oral steroids in children with positive PCR or those who look like having MIS-C. The temptation must be resisted. I suggest that every pediatrician should discuss the role of steroids with another senior pediatricians, and there should be no self-medication of steroids. They may be harmful if you have a MIS-C mimic like typhoid or typhus. In mild cases, certainly steroids are not indicated. In moderate and severe cases, steroid given at the right time, right dose, and the right duration. That too, dexamethasone 0.15 milligram per kg OD or methylprednisolone equivalent or oral should be good enough, and they should be continued for 5 to 7 days and then tapered over 10 to 14 days. I would strongly suggest that every general pediatrician who's practicing should think twice before starting steroids, and we should avoid starting steroids in the first 3 to 5 days of illness. We should have a discussion with a senior colleague and then only start steroid therapy. In fact, I have seen quite a few children who have been diagnosed as MIS-C based on COVID antibodies and a CRP of 60, being given steroids, ultimately turning out to have some other infection. So we should be careful. Finally, I would end my discussion with the prediction of the future of pediatric COVID. I don't know whether I'd be right or wrong. In fact, I predicted there won't be any third wave, but I have been proved wrong. Of course, I predicted third wave will be mild only in pediatrics. I hope I would be right. But let me predict the future of pediatric COVID. This pediatric COVID is going to become seasonal for us. It is going to increase our revenue during the winter months every year. It's not going to go away from us. It's going to behave like flu or RSV or rhinovirus and other viruses. When sick, we can wear masks, but I'm sure in the next 6 months to 1 year, school children will not be wearing masks, and people in pubs, people in hotels, people in markets will not be wearing masks. Whereas when they are sick, they'll be wearing masks and staying home. This culture will continue. And we will definitely have more sophisticated COVID rapid tests with 100% accuracy. Every parent will do that and come to you and advise or ask for advice, or they will have a teleconsultation with you. Our teleconsultation practice will improve. And more kids will definitely be vaccinated against COVID. The age will come down from 15 to 12 and then below, then 5 to 12, then below 5 also. And last but not the least, I don't think we can get away with COVID boosters every year. I hope I am proved wrong so that our children as well as adults don't get boosters every month. Thank you very much. Please mail your feedback over to the moderator. Thank you very much.
Thank you very much, sir. I'm sure you gave a very useful and fluent lecture on the whole management of COVID in children. You have given the recap of management of COVID in children, not only Omicron. Thank you very much for that, sir. And I'm very it's heartening to hear that only one case of Omicron has been admitted with MIS-C. Only one case I think your institution has reported with MIS-C. And comorbidities are the cause for death than the virus itself in almost all the cases. It is the scenario here also, sir. We have not lost any children due to COVID here in Madurai also. And testing, regarding testing, one simple thing what I say is not all fever require testing. Maybe all fever with ILI symptoms will require testing. That's what the ICMR or the government says. Only if they have, along with fever, rhinitis, cough, sore throat and all, then we are supposed to test them. And regarding my word regarding home testing, whether it is reported or not to ICMR, actually I have personal experience with that. Actually, what they say is if we register it in that app and test it, that result will be going to ICMR and the result also will be coming in a form to us as is positive. So if it is done through the app, I think that also will be registered in ICMR portal and that will be shown as positive in the government data also. Sir, what about testing the sick children when they develop fever, when they are in ICU, sir? Are you doing it, sir? If a child is there in ICU for some illness and a child becomes febrile, do you test it for COVID and do something or just leave it, sir? That's one question I want to ask. Number one. Number two, even if the D-dimer is very high, if we are not, we need not give anticoagulants, that is low molecular weight heparin. Why should it be done, sir?
Yeah, very good question. Thank you, Dr. Balashankar. Now to the question of testing for COVID-19. If somebody is asymptomatic as having only mild symptoms, you said influenza-like symptoms. Most influenza is only mild. 90% of mooku shali is with fever is our breadwinner viral URI. I don't think there is any need to test for COVID in an otherwise normal child if there is an influenza-like illness. If you test, yes, you will pick up positivity. even if the test is negative, even your PCR does not rule out COVID-19. The child could still be having COVID-19, could be transmitting the infection to others, even if the PCR is negative. To do it on somebody who's asymptomatic is going to only add to the family's tensions and mental trauma and stress and unnecessary antimicrobial prescribing, self-medication. Because most of the time, the parents would be positive, the parents would be on azithromycin. They'll come and ask you, can I give azithromycin to my child? So that is number one. So there's no need to test. With regard to mildly symptomatic children, unless you have somebody with medical complexity, I like the word medical complexity. Medical complexity is a high risk factor. What is medical complexity? It may be underlying leukemia, underlying lymphoma, a child who's on high dose steroids for nephrotic syndrome or for SLE, somebody who has primary or secondary immunodeficiency like HIV, somebody who has got a chronic lung disease, somebody who's debilitated with grade 5 disability with cerebral palsy or a degenerative disease, somebody who's got chronic liver disease, post-transplant victim. In such cases, yes, you can test if they are asymptomatic or mildly symptomatic to pick up the infection early, counsel the parents effectively. But the counseling is not going to be different whether the child is symptomatic or mildly symptomatic. It is going to be the same. All you have to do is to spend a lot of time talking to the family about the warning signs. In fact, I get at least one teleconsult every day from some of the parents saying, my father is positive, my husband is positive, my child is there 1 year. It looks like the child is developing fever and cold. The child looks warm, temperature is normal. What do I do? It's simply paracetamol, patience, waiting for warning signs, and reaching the hospital or a COVID care center if there are any danger signs. And those danger signs of COVID-19 are not very different from the danger signs of any acute febrile illness in pediatrics. And we should counsel. Coming to the mildly symptomatic influenza-like illness, there's no point in testing. We are not going to give therapy. We should counsel them to isolate even otherwise, ask them not to meet their grandparents, self-isolate at home, keep quiet, wait for warning signs, and not give unnecessary medication. In fact, one new thing I have added to my armamentarium as a placebo, in these children with influenza-like illnesses who have cold and cough, I have added a new remedy now, which has been recommended by the American Academy of Pediatrics. It works very well to tide off the pressure of giving antibiotics and cough syrup. I ask them to give 1 teaspoon of black honey, routine honey, 3 times a day, above 1 year. I tell them there is good data from US. The moment you say data is there from US, they will all agree immediately. So I ask them to give 1 teaspoon honey 3 times a day. They will think it will work. And in fact, 1 or 2 parents have called me and told me, sir, this has worked better than many cough syrups. Thank you very much after 2 days. So that's a new armamentarium. I would request my pediatricians to friends. In fact, I write a prescription nowadays. Give 1 teaspoon honey 3 times a day. Mildly symptomatic COVID. Go home, watch for red flags and come back if necessary.
Yes, sir. What about this D-dimer, sir?
Yeah, D-dimer is a marker of vasculopathy. It only tells you that there is some vascular endothelial injury. Interestingly, we looked at all the D-dimer values in our hospital, but I have not sat down and worked out a paper on it. I must do it. Gives me an idea. Even in all those children who were COVID negative, D-dimers were very, very high. This test, which we have not been doing earlier, we have started doing, and we find everything is high. So D-dimer high levels by itself is not an indication for anticoagulant therapy. The other risk factors should be assessed. Irrespective of D-dimer, I would consider giving anticoagulant therapy with somebody who's in ICU, who's being ventilated, who has a central venous line, who's obese, and who has underlying comorbid condition like leukemia or even like lymphoma or immunodeficiency, to consider giving low molecular weight heparin. And based on D-dimer alone, I wouldn't take a decision on low molecular weight heparin. I would request my pediatrician colleagues not to do D-dimer for every case of mild COVID or even moderate COVID. Somebody in ICU, somebody who's having MIS-C with shock, somebody who's in ICU, you can consider doing it. And please take help from your hematologist before deciding to give low molecular weight heparin. You may end up with a bleeding diathesis rather than with a preventing thrombosis. Again, there is a nice paper in Archives of Disease in Children last year on the analysis of deep vein thrombosis in children with COVID-19. There is absolutely no correlation between D-dimer levels and the occurrence of thrombosis. Because adult data is different, adults will be aggressive. In pediatrics, it is better not to be aggressive with D-dimer use and also low molecular weight heparin. However, we should not forget to give aspirin in all those children who are diagnosed to have MIS-C, taking all precautions.
Thank you very much, sir. Thank you. I think, you want to take the other questions, sir, or at the end you take, sir?
Yeah, you can end it over to, we'll go to the next session so that we'll hear more from our more distinguished expert, Dr. Dhiren Gupta.
Okay, thank you, sir. Thank you very much, sir. Thank you.
Thank you, thank you, thank you. The next session will be moderated by Professor Yael Arasi, the Director and Superintendent of the Institute of Child Health and Hospital for Children, a very senior pediatrician, very distinguished pediatrician and pulmonologist. Over to Professor Yael Arasi, madam. And I have great pleasure in introducing the next speaker, that is none other than Dr. Dhiren Gupta, who's already raised his hand. Dr. Dhiren, of course, we'll have more and more questions at the end of your talk. It's all yours. Dr. Dhiren is the director at the Sir Gangaram Hospital in charge of the Pediatric ICU. Dr. Dhiren Gupta is a pediatrician par excellence for various reasons. One, he's a pediatrician and a radiologist and an ultrasonologist. He's a pediatrician and a pediatric intensivist. And more importantly, he's a pediatrician and an eloquent communicator. In fact, he is well known for his presentations. Then he has been handling not only pediatric COVID and also adult COVID, and handling ICU care for pediatrics as well as adult medicine. And I thought he's the best person to share personal experience of the Indian scenario of adult and pediatric COVID. Over to Professor Yael Arasi, madam. Thank you very much.
Good evening, everybody. Thank IAP for this wonderful and the pleasant opportunity to moderate the session. I'm sure Professor Dhiren Gupta, who is the HOD of Intensive Care and Pediatrics of Gangaram, as Professor SP said, is going to give a really a brain-warming, storming session on third wave and vaccination. I'm sure many will have queries now because we started immunizing children and what is the picture in the third wave. So we are looking for a wonderful session by you, sir. Over to Professor Dhiren Gupta on this talk.
Thank you and good evening, Bala sir. And actually, I didn't knew that it is going to be presentation. So I thought it is going to be just an question answers. And so when I found that probably I have to present, so what I did past 5 minutes, I just extracted few of the slides which I made for other presentations. And most of the time we'll spend on the question answers. Probably people have more question answers. So, just 4 or 5 points I would like to discuss regarding just experience I'm going to share, and rest I told you that I want that more and more questions we expect from the people and we'll try to answer. First of all, we all know that Omicron is a mild disease, and now it's not based on just the Western data, but on Indian experience also. This is the 4th week we are into it, right? So everybody knows that Omicron is in a mild, and I've just taken out that slide with the microbiological perspective because we have got wonderful presentation by the epidemiologist and microbiologist. Now, as per my experience, the major difference, I could differentiate whether it's an Omicron and Delta, because in Kerala, there's still 10%, 15% Delta. In some of the states in the Maharashtra, there are some Delta. So people are using drugs like monoclonal antibodies, remdesivir, just making the people scared that you can have 5% Delta, so take it. So we need to differentiate them clinically. It's not very difficult, but it's not 100% proof. One is that Omicron mainly affects the upper respiratory tract infection. And what I found that the cough usually used to come from the throat, and it used to be like a wet cough as compared to the dry cough in the Delta or the Alpha and the Beta wave. Second, running nose and headache used to be in the almost 100% of the patients, almost 100% of the patient, less discharge in the Delta wave, and of course, less headache. There was something like a loss of taste and smell, around 5 out of 500. The adult patient I had, there was loss of taste and smell. So it was not an absolute criteria. And one more point what I noticed is that there was a less time between the exposure and the symptom development. I found some of the kids having just 12 hours of exposure and they developed symptoms. So average time was around 3 days or 2 days as compared to 4 and 5 days in Delta, 5 and 6 days in Alpha and Beta. So this was the difference. Another point is very important. None of the family member was spared. Previous speaker also said the same thing, that none of the family member, a family member of 10, all will got this Omicron as compared to 2 or 3 in the Delta. Now, in the last wave, I had around 800 families, and I was surprised that around, I could say, 1/3 of the family approached me. And while talking to me, I found that they were not talking about elderly at all. Even if the severest of comorbidity, other than immunocompromised or very fragile state, this disease has shifted from adult, means elderly to adult to young adult and adolescent age. I'm talking about symptomatic disease. We all know that mild, moderate, severe is based on the oxygen requirement and the lung infiltrate. But I'm talking about symptomatology in form of high-grade fever, chills and trigger, body ache, that was mainly confined to the age group of 11 to 40 years. Beyond 60 to 70 years, people were more worried but didn't have symptoms. And that was uniform in all the families. None of the patients none of the families, talked about the elderly this time as compared to the Delta wave. So this was the major difference which I noticed. Now, this was the data of my patients, or these all are OPD, or you can say phone calls, and 70% for doctors. And out of, say, 1,200 adults, I'm talking about, say, more than 18 to 20 years old, fever just subsided within 3 days in almost 90% of the patients. More than 3 days fever was just in less than 5 to 6% of the patients. Out of 5 adults, only 15 require oxygen or drugs like remdesivir. And almost 90% of the patients who require oxygen or require drugs or steroids either were suffering from Delta, the type of infiltrate, but most of time they were immunocompromised on active steroids. That was my observation. None of the patients, even with the diabetes, even with the hypertension, even with the obesity, even the age group 90 plus, I'm not talking about 50 to 70 age group or 70 to 90, I'm talking about 90 plus age group. None of the adults actually land up in the problem in form of a moderate or severe disease. Mild headache and sore throat used to be present in almost all. In some of the patients, there was anorexia and vomiting. And as I told you, elderly, they were least symptomatic. But those patients who developed symptoms, they had combination of dengue with influenza, nasal discharge of influenza, and body ache and bone break, you can say, the pain is of dengue. So this was the combination. So I'm trying to raise a different level of, discussion in vaccination. We all have tired of hearing that, okay, you take vaccination, you will be able to save the life threatening. If same type of Omicron again comes into as an epidemic, or 6 months back, 6 months down the lane, 1 year down the lane, some new mutation come and you find, okay, something like influenza with mild disease more prevalent, but more symptoms. Shouldn't we be saved of symptomatology by taking vaccination? One, we all know that severe disease is going to be, less in this type of Omicron virus. Why I should be symptomatic? So that's why I was raising this question that 4 weeks, say, if I take vaccine today, and next 4 weeks, it is going to be the peak of antibodies. So that should coincide with the probable epidemic, which most of time we come to know a month back, a month before that. So that is my main question, which I want, in this wave also, I took the, you can say, precautionary dose on 25th of November, not on the 1st of the January or 10th of the January, because I knew that this wave is going to come in the January session. Now, regarding adolescent, as I told you, 80% of the adolescent who were symptomatic, though 90% may be asymptomatic, but 10% who developed symptoms had 104, 105 fever. And a lot of patients, more than 60%, had lot of shivering. Despite they were afebrile, they were having shivering. So symptomatology, symptoms were quite severe in this wave as compared to, moderate disease, more shadows in the lungs, but symptomatically it was less. Hypoxia was more dominating in the Delta wave. Regarding our inpatient data, we have opened up our ward, pediatric exclusive ward, where ICU is also there. We had around 35 patients and 10 required ventilator support. And these ventilator support were NIV and invasive. And just half an hour back, we put in a child on high frequency ventilator. And this was a case of nephrotic syndrome. And I'll show you 2-3 cases. This is a case of group which we shifted in the ICU. I'll share these cases. And most of them were comorbidities. So in many of the cases, which I'm talking about 35 patients who require inpatient in present Omicron as compared to Delta, we had more inpatient pediatric patients. But moreover, it was a bystander rather than actually COVID-related pneumonia related with the Omicron. So what practical point I could gather and share? Over the time, surface cleaning now should go away. Less use of PPE. We should save environment. If this type of wave comes, probably we should stop testing in all the patients. And we should take it as just a influenza. If I develop influenza, nobody asked me to have isolation for 7 days, 10 days. Once you are asymptomatic, you join the hospital. So over the time, we should be less stressing on too much testing and isolation. Only N95 mask. I am fortunate, didn't have COVID yet, and I worked lot in adult COVID ward, and there were two, whether it's alpha, beta, delta wave, whatsoever you can call. Less time of isolation, as I told you, over the time, this isolation period should go down and we should take away. And whether it has been reduced because of lot of facility, lack of resources, or actually data, because if you look at the data, it's Japanese data, They're conflicting data, and many of my patients have persistence of viremia even after 10th day or 12th day. In 3 patients, on day 1, they had symptoms, then they became asymptomatic, they had COVID negative on 7th day. Again, they developed fever and rigor on 15th day, again COVID positive. So these type of unusual stories will come and will go. This happened in the Delta also, in the Alpha also. But over the time, looking at the severity, they doesn't have any value, and probably isolation time, unless there is a severe comorbidity, it should go away, and testing should also go away. As I told you, more upper respiratory tract infection, and fortunately or unfortunately, second day rapid antigen test, which is available in the nearby chemist, was coming positive. I would say on second and third day of the symptomatology, it was almost equal rated with the PCR, RT-PCR. And as I told you, there was infectiousness was so much that in same room, unlikely somebody will be escaping the infection. So that's why there used to be policy for the newborn baby that keep the baby 6 feet away from the mother. And once the baby is on feed, just wear a gown and mask and feed it. I think that we need to revise all the guidelines, because you cannot escape the infection. Better to stay. You know that newborn, whether it's a mother or this is a low risk age, and less invasive disease, hardly we use drugs. And the cycle threshold, some people say that cycle threshold should be taken as the sign. If low cycle threshold, probably Omicron. This is all hear and say. I did not find in my 500 patient data. And what is the most common spectrum? Is just an acute COVID asymptomatic or just upper respiratory tract infection? And what was the most misused spectrum? This was this one, high risk without hypoxemia. Whom you call high risk? Is it a comorbidity? 50% of Indian population beyond 40 years have comorbidity. Are you going to give antibodies to all these patients? Whosoever is money and can access to corporate hospital or where physicians are involved who can make you scared, they normally received antibodies, and most of them, they themselves were doctors. And so acute COVID pneumonia, I told you only 15 patients I saw this time out of 500 where I need remdesivir or steroids or enoxaparin. And as the previous speaker said, that even role of enoxaparin is going down, and as well as we are not chasing D-dimer even in the MIS-C cases. So probably the significance of D-dimer in pediatric, if you take some random sample of simple typhoid, simple dengue, you'll find 1,000 times the D-dimer in pediatric age group as compared to the adult group. So we cannot have the same comparison. Just 2-3 cases I just inserted 5 minutes back. I want to share. This is a patient who came day before yesterday in the evening. I got a call that a 1-year-old who has ingested some this very sophisticated name. This is something like antiseptic, a concentrated antiseptic, which you dissolve in 1 liter of water. You take 1 spoon and you dissolve. This is dimethyl ammonium chloride. I searched on the net, it was difficult to find, but I found that only symptomatic treatment has to be done. This patient came to our emergency because patient was getting drowsy. Now 12 hours, say 12 hours when patient came to us, he was irritable because parents tried to induce a vomiting. He had little bit fast breathing. He looked dehydrated. We got an COVID PCR that was negative. We do for all the patients who are likely to be admitted in ICU in the ward. It was admitted in normal ICU. I saw the patient. I spent almost 15-20 minutes with the patient. I'll show you this type of stridor patient was having. I don't know if it's audible or not. So now on an X-ray, initial X-ray, it was normal, but within 12 hours, we found there was a stipple sign. I could not explain this type of stipple sign, this type of stridor and swollen tongue, just based on taking some, ingesting some 1 ml or 2 ml of this dye. So I repeated RT-PCR yesterday around 2 p.m. And within an hour, we found that it was RT-PCR positive. It was a COVID. So it was a croupy-like. He was just behaving like a croup. So we give remdesivir. Of course, it can be questionable. The patient already was getting steroid because there was a lot of proof. Now, this is another child, a 3-year-old who is on induction chemotherapy, 4th week. It means past 4 weeks, he was on DEXA. He's immunocompromised. Every week he used to get chemotherapy. As a routine screen, the COVID test came positive. So chemo was given in the COVID ward. After 2 days of discharge in home isolation, patient developed vomiting and cold extremities and presented in a gasping respiration and septic shock. The patient was definitely suffering from severe disease, but we did not give remdesivir because we knew that the septic shock is probably not linked with this COVID, and chest X-ray was absolutely fine. And 5th day patient was off ventilator and ultimately recovered. So of course, still remdesivir role in pediatric age group is very doubtful, as Dr. Bala sir said rightly. This is another 13-year-old child who day 1, she became drowsy. Probably we thought of vasovagal shock. She also had very high grade fever of 105. She had chills rigor. She fell on the floor. We thought of vasovagal. She was rushed to emergency despite of fluid boluses. BP was 80/30, no fluid response. And we started on norepinephrine, recovered after 24 hours. Though patient didn't require any inotrope after 24 hours, though she was RT-PCR positive, CRP was 36, not negative, wrongly written here. Blood cultures trial, we could not find any cause of this shock. It looks like staphylococcal septic toxic shock syndrome. Though we gave remdesivir again, but it is again debatable. Should we have avoided remdesivir because chest X-ray was normal? This is another 13-year-old. Probably in this type of patient, you won't argue that should not have been given remdesivir. Something like this type of argument is a case of chronic lung disease on 2-liter oxygen, on steroid for past 2 months, developed fever and cough for 2 days. COVID RT-PCR was positive. In this patient, what is the, we say, new avatar of remdesivir, that you give remdesivir for 3 days in immunocompromised patient, you may be able to save the hospitalization. So I gave remdesivir to this patient, and he got remdesivir at home and did not escalate the steroid. This was the chest X-ray. Patient usually have this type of chest X-ray because he was suffering from chronic lung disease. He's a case of Down syndrome and ultimately recovered. Now, these were the few cases because, as I told you, I was not prepared for the presentation, so I deleted most of the presentation. So, but I wanted to share this type of presentation, and so to have question and answers on the use of remdesivir. Because if you look at the government of guidelines, they clearly say that no role of remdesivir in less than 18 years. What is happening? There's a lot of discrepancy what government says and what clinicians do, right? So because we individualize each and every case, so each and every individual read up all these guidelines, but still they get all these drugs. So we need to rationalize, we need to individualize these cases, and definitely question and answers are more important than this presentation. Now, regarding the vaccination, as I told you, one point I raised that if I want to save symptomatic disease, I want to save Omicron-like infection, shouldn't we coincide a precautionary dose 4 weeks before any suspected epidemic which is going to come? One, because we know that in this way, whether patient was vaccinated, whether patient had Delta infection, whether patient unvaccinated, all were in same group, because Omicron itself did not produce life-threatening disease. So in future, if we experience same type of infections like Omicron, in subset of doctors, it produces lot of symptoms. Even 15th day, they are having lot of body ache, but still they are mild because it doesn't have oxygen requirement. We all know that Omicron doesn't penetrate the lung. So future, probably we need to have Omicron type vaccination, Omicron based vaccination along with Delta. And we need to coincide, we need to take these boosters 4 weeks before the suspected or expected, which we all hate COVID, but we can't help it. Which vaccination? If you are Omicron infected, if you are not Omicron infected. So my take home is, if I'm Omicron infected, I would like to wait for 3 months. and look at what type of vaccinations are available there. We all know that Covaxin is a poor antibody inducer. So symptomatic disease prevention is unlikely, right? Probably we may have something like Novavax vaccine, which induces antibody response. Likely that will be my choice, right? Vaccination benefit in children, we need to have very safe vaccine. So Covaxin is pretty safe vaccine if you consider safety margin. Is this going to prevent MISC? What we have heard about, mRNA vaccine, we have heard that mRNA vaccine prevents MISC in US to the amount of 90% and 75% in Germany. This is all not very good data, but they've initiated this type of talk. And so these are the questions I would like to raise. So I finish my presentation, and it's all question and answer that I am more interested.
Over to
Thank you, sir.
Over to Professor Eliarsi.
Okay, sir, thank you. Though you say you are not prepared, we really got a lot of information. So I too have a few queries, sir. Before that, sir, we agree with you. That is not to give responses, all of us agree. But in a case-to-case basis, when you think it is going to be a life-saving decision, yes, I think it is a decision of the physician to give. So 1 or 2 cases we may have to use. The same thing like CT. We don't take CT at all. But then if one particular case who's very sick, who's not improving, progressive pneumonia, and if it is pneumonia at all these conditions we do give. So my few questions, my doubts would be, so about the vaccination. So we are giving Covaxin, but we are only giving it to recently. So I don't know whether the impact of vaccine on MIS-C, whether we can expect in this way because it is too early. Whereas Pfizer, obviously, the Pfizer vaccine, which has been used not only in the US, it has been used in other countries, including Middle East. Maybe they are reporting less of MIS-C. One more this thing, sir, what is your observation on this? Whether you think it is really a decrease in MIS-C? We are seeing a lot of, now in the third wave, as Dr. Bala said, we are getting only a few in MIS-C compared to the second wave where we had large number of cases with a lot of complications, shock, rashes, myocardial failure and all that. But GBS, cases of neurological, we are seeing large numbers suddenly. Today we have only 5 COVID positive in our isolation ward. At the same time, we have at least more than 5 or 7 cases of GBS, 2 COVID antibodies positive encephalitis. And we cannot obviously give importance to antibodies, everybody. So what is your opinion on this, in this third wave, effect of vaccination and the complications?
Yeah, I feel that this time when we started vaccinating either kids or precautionary dose, that was the wrong time and wrong part of the epidemic, because we knew that at the end of December, epidemic was going to peak. And many of the patients actually got infection from crowded vaccination centers. And the same thing happened in the Delta wave. And probably the decision should have been taken on December 1st week. That should have been the best time. Now we move forward. Whatsoever is done is done. Now we all know that Covaxin is a poor inducer of the antibodies. It will take, after second dose of the Covaxin, another 28 days to have sufficient antibody response to give protection. And we were fortunate enough that Omicron turned out to be milder. So what I could say that the present vaccination for pediatric age group is not going to benefit them in the present scenario. It is good for the future, and very important to vaccinate our pediatric age group to gain confidence among parents. Parents were feeling guilt that they got vaccination and how they can send their pediatric patients to school and college without vaccination. Probably that is the major benefit, because still we need to prove regarding the benefit of the MISC. Now there was another study that which says that if in a group, in a family, both parents are vaccinated, then there is chances that 75% chances of less chances to get infection inside the home, right? Yeah. So probably it is going to be applicable to pediatric group also. Suppose in a family member, there are 6 members, 2 elderly parents and 2 kids. One is around 12-year-old and one is 2-year-old, right? So 2 years, we know that we are not going to vaccinate. If we vaccinate 12-year-old and all the elderly members, probably you will be able to save a local, by making a local herd immunity for that 2-year-old. So if I get a vaccine which prevents the carriage state also, like nasal vaccine, I'll be more interested in taking that nasal vaccine 4 weeks prior to any expected wave. And I would like to give the same vaccine to the child between 5 to 12 or 12 to 18-year-old who is going to school. So to prevent that infection, he should not bring infection at home. So that is my take home.
Okay, sir. Is there any this thing that suppose so many have got infected? I'm sure most of us, and we are all due for our third vaccine. Suppose if the ideal will be to take after 3 months and we have not tested, is there any chance that more complications can occur if we take the vaccine earlier than 3 months? That is one worry, I think, because we have seen thrombosis in children, in the MIS-C, in the COVID-2 and all this dry gangrene and all in the second. So will there be any thrombotic complication adults, if not in children, if you take a vaccination earlier?
Ma'am, COVID, I think regarding that side effect you are talking about.
Yes, sir.
I would say
any problem.
Indian vaccines, moreover, been very safe, right? But
yes,
what happens in India, we try to hide the data, right? And I know many of the patients who get actually some side effects, but they were refused to refuse to register their complaints and all that. So what I would like to say, if you look at the Omicron, what is my experience is whether you were vaccinated, whether you were not vaccinated, because it did not produce severity of the symptom, they all were same. We are interested in decreasing the symptomatology and also decreasing the severity. Now, our aim is to prevent 2 types of infections. One is symptomatic infection, which will happen in next wave because this Omicron looks like dying. Second is we also want to save ourselves from endemic Delta because Delta is going to stay. We are scared that if I am not fully immunized, suppose you check your you got an Omicron and you were sure by testing that you got infection. Definitely you delay it for 3 months. There is no doubt about it. But when you are not sure about whether you got infection or not, probably you can check your antibodies. That's why I was arguing. As a doctor, if I was not sure that I got Omicron or not, I would like to check after 2 weeks my antibodies. If antibodies are sky high, it means I actually had Omicron. So any human who has actually received Omicron infection, a natural infection, we should delay not only 3 months. After 3 months, we should decide what is the situation of epidemicity, what is the situation of endemicity, and what Dr. Bala said, we should know our epidemiology, local epidemiology, Indian epidemiology, and what type of vaccines are available, then we should move ahead rather than just blindly following the protocols.
Thank you, sir. Thank you so much for the kind interaction, and thank you again for the wonderful opportunity. Over to Professor Bala, sir. Thank you.
Thank you, Professor Dhiren, Dr. Dhiren, for that wonderful presentation. In fact, you're not going off. We have another maybe few minutes. In fact, I wanted to ask Dr. Ramanan 2 questions and Dr. Manoj 2 questions. If Dr. Ramanan, what about IVIG versus steroids in MIS-C? What's your take? Should it be next Omicron-induced MIS-C? Next case comes, do I give IVIG or give steroids alone? What will you do, Ramanan?
I'll tell you what I'll do because I can't tell you the data since we're still looking at it, and hopefully it will be coming out in the next couple of weeks. If the child is above the age of 5, I would give IV methylpred because it's cheaper and more affordable. And if the child is under 5, I would give IVIG as per Kawasaki because it's very hard to discriminate between Kawasaki and MIS-C.
Okay. One more question to Ramanan. How often you end up giving enoxaparin to children with messy and severe COVID in UK?
Extremely rarely. So we only give enoxaparin, as you've highlighted and as others have said. There's no need. We've been using D-dimer in rheumatology for a long time. There's no need to react to a D-dimer. As you said, it's a marker of vascular endothelial activation, and we will only give low molecular weight heparin if they are morbidly obese, have a prolonged duration. So all of those usual risk factors which you will consider for venous thromboembolism. But a high D-dimer on its own does not make us choose anticoagulation at all.
Okay. Two questions to Dr. Manoj. Sir, when do you expect somebody like me to go to hospitals without a mask? Or you are not going to see it? Sir?
All of us want an answer, sir.
When can I go to the hospital, go to a hotel without a mask? When can I start that, sir? UK has already started doing it. When is it going to happen in India, sir?
I have not been using mask for last few days, sir.
Sir, you have not been using. I am looking for the day when I am unmasked.
Yeah, I agree.
To my parents, my relatives, my friends, and also to the young children whom I treat. When do you expect that to happen, sir?
Yeah, see, sir, in next 1 month, we are going to see these Omicron cases coming down. And I'm sure whether you recommend continued use, people are going to reduce use of mask because people's reaction
Sir,
is based
can I
on
speak, sir, please?
Dr. Jay Kumar.
1 minute.
Yeah.
1 minute. 1 minute. 1 minute.
People's reaction,
Okay,
because that
sir,
we have
okay,
seen
thank you,
through, we have mask use surveillance in Chennai.
Yes, sir.
We basically have been seeing what proportion of people use mask correctly. So we saw that whenever there was a wave, increased number of cases, adherence to mask use was higher. So as soon as we see the less number of cases in between waves, the adherence was low. So whatever maybe the government was telling, and there was a recommendation from government of India also too, that you should always follow this non-pharmaceutical intervention. But people's behavior, you for a longer period, you can't force them to do this. So when they see this as a threat, the number of cases are increasing, they are going to follow this intervention, non-pharmaceutical intervention. So if we have another surge of cases in after 3, 4, or 5 months, I'm sure we'll have to use non-pharmaceutical intervention. So I think we'll have to wait. I don't have a answer right now, an answer to say that on this month you stop using mask. We have to basically judge this response based on the number of cases, as somebody mentioned, based on the local epidemiology of the case.
Sir, another epidemiological question, sir. Do you think this masking will reduce the incidence of other viral infections as
Certainly,
well as
sir. Certainly. Especially like this is like measles or TB. I'm sure. Last year when there were reports of reduced notification of TB, one hypothesis was because it might be because of use of mask. But certainly diseases like measles, we have lesser notification last year, and and mask use certainly must have contributed for this. Of course, there is no documented or there is no data to support that. We only have no control group, I would say. But yes, measles notification last year, if you see nationally, substantially it has been reduced. The number of cases are reduced.
Okay. 2 questions to Dhiren. Dhiren, have you used molnupiravir so far? And how many times you have given cocktail? Not lytic cocktail or alcohol cocktail, the antibody cocktail.
Sir, I gave to one patient, I prescribed molnupiravir, and till date I am repenting that why I prescribed. On 4th day, she was a young female and she was complaining of severe headache and body ache, and I don't think that molnupiravir did anything. On 5th day, most of the patient became asymptomatic. Probably that was the wrong decision. Otherwise, nil. And secondary cocktail, And I think I got around 75 requests from the doctors on day 1 and day 2. I did not share my exact number type of patients in adults in the present conference, but I did not advise to any one of, but still despite 10 of them got cocktail antibodies, and there was no difference between the two. Especially when we talk about cocktail antibodies, as you rightly said, we don't have true cocktail antibodies that can oppose the Omicron. And why Omicron will need cocktail antibodies, especially when you are vaccinated and the severe disease can be saved even if you by chance acquire a Delta. So all these studies were done during unvaccinated time and during Delta time. So presently we don't know even the efficacy of sotrovimab in Omicron. Is it going to work or not? So I did not prescribe even a single cocktail. Of course, in 15 of my patients, I do prescribe the remdesivir. All were immunocompromised on day 5 also.
Okay. Professor Ailersi,
Can I
madam,
speak, sir?
anything else from Professor Ailersi, madam?
No, sir, nothing. It is just that I wanted to know how many are seeing cases like what we are seeing. So many neurological cases in this third wave. Nothing else. I think Professor Dhiren Gupta, as he said, we cannot really predict what is it related to, because we have also not really interfered with the children of with vaccination of 2 doses. So that's all to it. I think Dr. Jayakumar wanted.
Yeah. The problem of blaming COVID for everything based on PCR and antibody is becoming rampant. We really do not know. Somebody had put febrile seizures, somebody had put henox-conolin purpura, somebody had put GBS. We really do not know. Time alone will tell. I think it's already 7:07. I would conclude the session and hand over to the organizers, Dr. Rajendran and his team, for the concluding remarks and for the official thing. I thank Professor Ramanan, Dr. Murekar, and of course Dr. Dhiren Gupta for their time and for their excellent sessions, and of course the Professor Ailersi, Dr. Thangavelu, Dr. Balashankar for helping with the sessions. Thank you very much. Over to
ma'am. Can I speak, ma'am?
Over to the organizers.
There is one question. So one question
organizers.
from Dr. Jayakumar. I think he's been asking for quite some time. It's been missed. Dr.
Can
Jayakumar.
Yes, ma'am. Actually, let me get acquainted with you all. I am the secretary of IMA Namakkal.
Okay.
Yes.
Okay, I am basically anesthetist.
Okay.
Being graduated in KMC Mangalore, Manipal groups. Okay, but I am not doing the freelancing. I am not doing the anesthetist work, but I am running my own setup as a GP. But in my experience, as Dr. Dhiren Gupta and as Dr. Balasubramanian said, so I used to see almost 100 to 200 cases per day. Actually, pediatrics or everything, because as anesthetists, we know. So we treat the patients as per the body weight, we all know. So as they said, the vaccination, all those things, in my experience for 2 years, I'm just staying in my clinic. I don't go home because my mother is with a comorbid disease, and then she's very old. So just to save her, for past 2 years, I'm just staying in my clinic and looking after the patients, just to save her. So in this scenario, as Dr. Dhiren and then Dr. Bala sir, as they said, so just symptomatic treatment is enough.
Okay. Okay, sir.
Maybe severe cases.
Sir,
I'm doing daycare services.
Very
in
good,
maybe severe cases, Dhiren sir said, you can go for all those cocktails.
Sir, well taken, sir. Thank you, sir. Over to Dr. Rajendran for
Thank you, sir. On behalf of IAP TNSC, I thank our organizing program convener, Dr. Balasubramanian sir, for painstaking arrangements and choosing the topic as well as international standard speakers. I thank Dr. Bala sir.
And I thank today's moderator, Dr. S. Thangavelu sir, and Dr. Elilarasi madam, Dr. Amma Chandramohan madam, and Dr. Balasankar sir from Madurai. And I thank today's speaker, Dr. Manoj, Dr. Ramana sir, and so all the Dr. my friend and good friend of me, Dr. Dhiren Gupta. So I thank one and all for this wonderful opportunity to given to IAP TNSC. And definitely will be benefited by everybody, and it's available in IAP YouTube channel also. And you can go and always see, and a lot of almost 300 participants in the YouTube channel also. I thank one and all for this wonderful opportunity. Thank you.
So please send the recorded version, sir.
Yeah, it's available in IAP TNSC website.
Okay, sir. Thank you.
Okay.
Okay, sir.
Thank you.
Thank you, sir. Thanks, everyone.
Dr. Ramesh Babu, yeah, you want to tell anything? Dr. Ramesh.
Yes. It was an excellent session from 4 o'clock onwards. Our Professor SBS sir's question and answer session was very informative. In fact, I went to attend the Central IAP office bearers meeting held by the Central IAP President sir. So I missed from 4 to 4:30 to 5. I missed it. But I later came and joined when Professor SBS sir was speaking. It was very useful. I think I felt it was a revision of the previous CME program where for the second way we conducted, IAP TNSC conducted. Very useful for all the participants, sir. We will be broadcasting it in our YouTube channel shortly for the persons who haven't attended. Excellent session. Thank you, sir. We will try
Sure,
to
sir. You're absolutely right.
services.
Excellent session.
IAP TNSC will utilize your services in the future.
Fantastic. It was. Yeah.
Thank you, sir. Thank you, sir.
Thank you, everyone. Yeah.
Thank you.
Thank you, sir. Thank you. Dhiren sir, thank you.
Sir,
thank you.
My pleasure.
Okay, sir. Thanks.
Bala sir,
Namaste.
thank you. Rajendra sir.